the highest disability, 10 is the lowest. So you can see your improvement. And that will also make patient to be happy. And you can also use that to say that, yes, your intervention is working or not working, instead of just saying patient improvement. How? So in research, you must measure an outcome. So is that outcome that you use to know that whether your treatment is working or not working? Then who should be in your study? If you are doing study, you have an inclusion and exclusion criteria. And in inclusion, you identify who are eligible to participate in your study. So that whenever you had who should be in you are thinking about inclusion and exclusion criteria, because you may have heterogeneity, homogeneity, and at the end you want to generalize. So because this generability of your study, depending on who did you include, which population you target. If you said population of low back pain, which type of low back pain that you? So you must be specific, non-specific low back pain, or patient with TB of the spine. So you must be which type of diagnosis, which age do you want to include? You want to include all gender, any ethical issues, why do you want to remove this and add this? So it's very important, and that will allow you to generalize when you finish recruiting to say, okay, this is working on so particular population, because you only include those one and you can only make conclusion based on your inclusion and exclusion criteria. And is this what is strengthening your study and will make it valid, because you have not included all set of participants. And it will also make you to justify it that, okay, this particular intervention is already working on patient with non-specific back pain, but it's not working on patient with different, another category of low back pain. Or it only work on patient, or you can just make argument that the intervention they gave it on knee pain, not shoulder pain. And shoulder is highly unstable joint because it get only its stability from the muscles. And so you want to try that intervention in shoulder. You can just do that to justify your studies. So anytime you want to look at the inclusion and exclusion, why do they include this? Why do they exclude that? And you can use that also to justify and carry it out on other study. So it's very important to identify who should be in the study and who should not be in the study. And I said we are talking about experimental design, and I said there is quasi-experimental, which is not true experimental design. So in experimental, you must do a random allocation. You must allocate, sampling. And this sampling is where you allocate your participant into a different, so that you will have bias that you all allocate those that are 20 and 30 years old into one particular group, while the remaining 40 and 60 years, they are in one particular group. You can see you already have a bias. And this bias means that only those younger adult in one group, older adult in one group, and that can affect the validity of the study. And that is why it's good to have a good sampling. So in this, we have random sampling, where all the participants has equal chance of being in one group or the other. Then we have systematic, you can say able 10 member of the population will be in one group. Then you have stratified sampling. You target your population, split them into different classes depending on the specific characteristics, either age, gender, and then you randomly put them, or you can classify it into cluster. You can divide them into cluster. different cluster, maybe different area, and now choose whatever, and you have a convenient sampling as because some volunteers or as they become available, because certain population you don't have the pool where you can take them. So as they become available, that is when you recruit them. So that is what we call convenient sampling. So as they come, or as you meet them in a particular place and include them into, and even in that, you can decide to randomly also allocate them into particular group. And you may have bias, because bias can affect the validity of the study. Bias in sampling, maybe you have volunteers who are maybe professional, or you have
Sorry,
somebody.
the bullet there is not actually our concern. So far, so why is not impeding the vascular supply?
At that point, like for a patient like that, it's not a priority, right? It's not a priority. I get you, right?
Why do you think it's like that?
The patient, no, they said the condom before she got there, the patient had died. The patient was not yet stabilized.
So please, can you mute yourself? Mute. You have recruiter bias. If, let's say, MRTB is recruiting or HCPC is recruiting who they wish to participate in the study, that's a bias. And other factors. You may have less privileged patients and you decided to be in one group, or geographical factors, that all this can be in one particular area. Most of them, they don't have well to do, or they are just socially disadvantaged for one reason or because of the geographical location of that. And all this can affect the sampling technique. And these are what we call sampling bias. And they can affect your validity of your study. So you try to minimize all distance. If you are conducting a research, you minimize any sampling bias. You minimize those that said they want to voluntarily participate. You ensure that you have equal distribution of such participants. And another factor also that can affect your validity of research is sample size calculation. And sample size is extremely important to ensure that type 1 and type 2 error is minimized. And type 1 error, type 2 error can affect the validity of your study. Type 1 error is once there is no actually significant effect and you said there is significant and you fail to reject the null hypothesis, you commit type 1 error. Type 2 error is when your sample size is too small to detect changes, and actually there is that changes in that population, or the intervention can detect change, but your sample size is too small to statistically detect changes. You said you commit type 2 error. So to ensure that these errors are minimized, you must have a good sample size calculation. And what do you consider in sample size calculation? You consider the power, that ability to detect an effect, to detect change, and usually the power is set between 80 to 90%. So what does that mean? 80, most of any time that you see someone is calculating sample size and he put power below 80 or 90%, then he has high chances of committing type 1 or type 2 error. And you take what you call significance, that's the chances of you making type 1 error. Usually significant effect is determined as 5%. What that 5% means, that you are saying you are 95% sure that all what you do is correct, except 5% that may result, we know we are human being. If you are doing anything, you may likely to make an error. So you are saying only 5% of chances of you of making error, and that's, so you are taking 5% as significant. So anything 95% you are sure is due to the outcome of your intervention. And that is the reason why you are seeing P is less than 0.05, and that 0. Basically is 5%. You are saying you are taking risks of 5% error that you make, but 95% sure that the significance you got from the statistics is 95% due to intervention. The remaining 5% that you said you take as P less than 0.05 or 5%, you are saying anything less than that is due to error. So we have 95% confidence interval and 5% due to chances of making type 1 error. So you have to take your level of significance, which is usually 5%, the power of ability to detect change, that you are saying your sample size is enough to detect changes. And if you take power of any 80 to 90%, you are saying you are able, sample size is good enough to detect changes. So any other things is, anything that happen is due to error. So any power less than 80 or 90%, you have high chances of committing type 2 error. And it's saying your sample size is not enough. So while considering sample size, you must consider power to be 80 and 90%. And your level of significance must be at least 5%. That you are saying you are taking 5% chances of making error. Any other things is correct except 5%. So you must consider these two things, level of significance and power, while calculating your sample size. And in most of the quantitative research, we include either control group, or we call it placebo or sham, whatever you call it, they are usually control. And it's meant to control your main intervention. And after, you may decide to give them the same intervention, but initially you take a control to ensure that the intervention that you want to give is purely that intervention. Then the other group, you can give them placebo, and placebo is also a control. You decided to give them something similar, like you can give a pill of sugar or a pill of any sweets, as if you are given something that is not harmful. All these things are part of what ethical committee used to check. You can give a sham. Sham treatment is different from placebo. In sham, you put something and you are not given, you just put it, like you put shortwave diatom without owning it, and you are saying you are given, or ultrasound you will be doing, but well, the ultrasound machine is not on. So these are different type of control group that you can have. So this is it when you want to, and after when you finish your study, you want to take the control, also give them the same intervention, because these are ethical issues. You must to give them similar intervention, you must to, because it's going to be beneficial to them. And in most cases, ethical committee, they don't want to have a control, because it's like you are not doing justice to that other group. So you must to give them, in most cases, they give them intervention, or you do crossover treatment. So when you finish, you cross over, the control will now receive intervention, and the other one will receive the control treatment. That's the placebo. And in most cases, now ethical committee, they don't want you either give the usual care and give your treatment, or ensure that you must give them something. Otherwise, you can't say somebody has one disease and you are not doing anything to him, and the other group, you are now giving them another treatment. So you must to balance between the two. The control ethical committee will, if you said you have a control, they will look which type of control. Do they give the control and intervention? Even if it is a usual care, you must give them something. Blinding and allocation. So in the quasi, you don't do all this blinding and allocation, and that is what makes it a quasi experimental. And in true experimental, you all do this blinding. And in blinding is what make an randomized control trial. Randomized is like a gold standard in experimental design, especially in health research. And in this blinding, you must to allocate a patient to a treatment or control via a randomized, like that sampling that we talk about. So you randomly allocate them into one particular group without knowing. Sometimes you blind patient to either know the intervention you are going to give him, or they will know that yes, they are taking particular intervention. That's the blinding. Or you blind the assessor, or you blind the statistician. So there is a way you can either blind your patient, the patient and the participant. You can blind the participant, you can blind the assessor, you can blind the statistician, or you can blind someone given that particular intervention. So we have a single blinding in which either you blind a patient or the intervention that is going to receive. He doesn't know that is receiving, this group is receiving exercise, another group is receiving a shortwave diatemy. But it's very difficult in physiotherapy or surgical intervention to blind patient for a particular treatment. You can have double blinding. You blind the patient and you blind someone given that particular intervention. And I said it's very difficult because of the nature of openness of the kind of intervention. If it is a medicine, you can just remove the pills, put it in a container that nobody can identify except you, that this is a paracetamol or this is a Septrin and so on. But because our intervention are more physical, it's sometimes difficult to blind the assessor and the participant. Even the surgical intervention too are very difficult to do that. So why do we do experimental, advantage of experimental design or research? Because randomization that we said earlier minimize the risk of extraneous variable compounding result. So like age that I gave example, if you blind or you randomize, the reason why that randomized control clinical trial are key is you are minimizing those risks. Age, you ensure that if you do randomization, the age, once particular age, they will be blind, they will be randomized into all the group. Group A can receive those group, they can have those younger age and they can have older age in a particular group, and the same group too. But if you just leave it without randomization, you may end up having one group having younger adult and another group having elder adults. And you have control over independent variables, allowed clear understanding of cause and effects. And you remember the independent and dependent variable that you set. So these are the advantage, because you are the one that's given, but you don't have the control over what will happen to independent and dependent variables. You have also advantage is pre and post testing control for time-related threat to the validity. So what does that mean? You have the control to measure pre-data and post for your control and your experiment. And it allowed you to have a powerful statistical manipulation and will reveal if there is any relationship between a particular group or not. These are the advantage of expert. Disadvantage, they are difficult to represent specific population, difficult to choose control, difficult to control extraneous variable, natural environment not always achievable in doing the research, patient adopt unnatural roles, sometimes patient can pick things, design like diversity, e.g. MDT was manipulate, is it manipulative diagnostic therapy? Yeah. So design in most of this like diversity. In what does that means? That you may not have enough of diversity in design if you are doing RCT. So before we look at data analysis, any questions, please, on research method? I will try to just summarize. As I said, in quantitative research, we have what we call, you must to measure a data. That is a key. And you have a measurement, you have a data that you are working on. And you must have a research question. You must have an aims and objectives of why do you want to carry out that particular study. And when we have different design, as I said, there should be a design, either cross-sectional, that is observational studies, or descriptive studies. Then we have the experimental studies and quasi-experimental studies. Then we have the sampling techniques. We have the blinding, we have inclusion as exclusion criteria, that who do you include in your study, and you now have randomly allocate your participant into one particular group or not, or another. Then you have a control group. Then we look at the advantage and disadvantage of this different design. Any questions? Before we do data analysis, any questions?
Oh, thank you for the wonderful presentation, sir. Actually,
Yes.
my question is with regards to the control group. You mentioned that we can have a placebo or we have a sham. Like, is the sham aspect that I need more clarification on?
Sham is like you assume that you are given a particular, well, you are not given any things to the patient. Then in placebo, patient is taking a particular things which is not harmful to him. Do you understand?
Yes, sir. Thanks for the clarification.
Yeah. So he will take something in placebo, well, in sham, you don't give him any, you just assume you are doing something. Well, in reality, you are not doing anything to him. And in most cases, in physio, we can only do sham because most of our intervention are physicals. Any questions?
All right, thank you very much for the beautiful lecture, sir. So I'm just curious to know, in what instances do we not require an hypothesis in a quantitative study?
Yeah, in quantitative, if you are doing an experiment and you want to test for something, you definitely require a hypothesis. Well, if you are doing descriptives, you just want to describe or observe a particular from the design. If you are doing observational, in most cases, you don't require hypothesis. Well, in experimental, because you want to test for something, so you definitely require a hypothesis. I hope this is clear.
Yes, sir. Thank you very much.
Yeah. So if you
Hello,
are
sir. Thank you.
out
Okay.
observation, you don't require hypothesis. If you are say you are doing cross-sectional design, you don't require hypothesis. But if you are doing experimental, you require a hypothesis.
Okay. Thank you, sir, for the wonderful lecture. Most people doing researches, the area they have a lot of problem is sample size estimation.
Yeah.
So I would like you to give us more light on how you think people can go about it easily. Are there applications? Is it software?
Yeah, there
And
is formula, there is application, there is G power now, there is also sample size calculation formula for cross-sectional studies, sample size calculation formula for experimental studies, and sample size calculation formula if you are doing experiment. Is it 2 group? There is also formula for that. Is it more than 2 group? There is also formula for that. And there is softwares nowadays. There is all this G power. They will tell you which power you want to, and the effect size that you want to assume. And effect size is just telling you that this maybe previous research, after their analysis, their effect size is more. So effect size is all about, yeah, please mute yourself. Please mute yourself. So effect size is about telling you the sample size they use in the previous studies is not enough. If they said they have small effect size in the previous studies, then they are telling you their sample size is not enough. So if you are doing your own, you put small effect size in calculating your sample size is going to give you large amount of number of participants that you are going to include in the studies. So if you are doing also, you are using a formula. Most cases for cross-sectional studies, what they require, if you are doing prevalence, let's say prevalence of low back pain, in the formula, most of the things are constants, like this significant level, which is the P5%, the confidence intervals, 95% confidence interval is constant. Then the previous prevalence. In the previous studies, let's say they find out that 30% is the prevalence rate of back pain in northern Nigeria, and you want to do a similar study in southern Nigeria. So you use that 30% in the formula for prevalence studies. If you don't know the prevalence, you can use 50% as in the formula. I wish there is time we are doing a physical, we will have all these formulas. But I can send
I want one of your patients over get for the chair. Mumbo.
Oga shagali ake yanzu ka tashi ko?
kira ka ai.
Okay.
Su ji na
Wa?
jikina.
Wa nan na. An yi jana'iza? Okay, yanzu a yi. Karfe nawa?
Yanzu ƴan uwan an kira mutum ba kunya yanzu ke cewa an ma ɗan uwan aiki amma ba wanda ya yi. Ba wanda ma ya yi.
Wani aiki aka mai?
Yasa ya borin kunya su sai ya haka sai wannan malam Isa. Ai ya je san ya tsida.
Na cire ruwan? Okay. Sai jiya aka mai?
Kuma an yi jiyan duka ba zai yi awa ɗaya biyu ba robar ta zari. Ko ba a mai ba.
Sai rikan dalala. A ina ake ICU ko ina? Ko dogon ɗaki?
Ya kuma wani hello?
Wallahi gaskiya. A general aka mai ko asibitin ne? Wai da ba kun ce an kai shi asibitin ba?
Hello? Can you hear me, please?
Yes, we can hear you, sir, from my side.
Okay, please, is it the explanation on some side? Is it okay? Any other question, please? Yeah, Yakubu. Anajine? Okay. So if there is no any other question, let's continue. Let's continue on the data analysis. So what do you consider if you are doing, what do you consider for data analysis? Factors to consider, you consider your aims, okay? Aims of the study, design of the study, and level of data. These are the key things that you consider for doing a data analysis. What is the aim of your study? And the aims, you remember, is derived from the research questions. Do you want to measure pain, pre and post? That's repeated measures for different conditions, for cross-sectional design, for different subjects. These are different design of the study. So your design will also determine the type of data analysis that you are going to use. Then aim of your study. Is your study just describing a particular things, or are you comparing, or are you going to correlate? Are you testing for association between one particular event and another, or are you testing for a relationship between one particular aspect or another? So then which, I said design, aims, and the type of data. Which type of data do you have? Your level of data, you know, data can be measured in nominal, ordinal, interval, and ratio scales. So these are if you want to understand your data very well, you must understand the level that you measure that data. We have nominal, we have ordinal, we have interval and ratio. Nominal and ordinal are also called qualitative data. Well, interval and ratio are also called quantitative data. So which one do you have? Is your data measured in quantitative or qualitative? So that will help you to know the type of analysis that you are going to do. So I hope you know what is nominal. This is a data allowed you to just allocate, like you say yes or no, allocate 1 for yes, 2 for no, right or left, 1 for right, 1 for left. So you just allocate for a group. You say group A, group B, group C, and you allocate A for group A, B for group B, C for 3 for group C. So that type of data is called nominal. Or your outcome measure is saying satisfied, not satisfied. You just allocate a data. Just for identification purpose, male, female, you allocate 1 and so on. And that is called, then ordinal data. And I said nominal and ordinal, they are called qualitative data, while interval and ratio are called quantitative data. Measurement or scale that allowed you to rank order your data according to the dimension you are interested. Like Likert scale grades such as 1, 2, 3, or level 1, you have in university, you have level 1, level 2, level 3, and level 4. So indicating that one grade is just higher than the other. Like level 1, they are lower, level 2, they are higher, 3, and so on. So this type of data, or you have a Likert scale, and this type of data is called ordinal data. And these two, I say ordinal and nominal, they are called qualitative. Then we have interval. Interval data assume equal intervals in the measurement. It does not have an absolute zero. Like you are using Celsius degrees, like temperature, Celsius degree centigrade. Zero does not mean that the temperature, there is no temperature. We can have -1, -2, -3, -2, -1, then 0, 1, 2, 3. So zero does not mean anything in this case. It does not mean an absent or quality or whatever. Example of that is temperature. So such measurements are called interval. In between there is equal intervals or equal. They're between 1 and 2 is 1, 2 and 3 is 2. So all those things, this type of data is called interval. Then we have the ratio. And in ratio, you can do all the arithmetic. You can add, subtract, minus, and multiply. Well, in interval, you can do certain, you can do addition and subtraction, and multiply. You cannot do some certain arithmetics. Well, in ratio, you can do all the arithmetics. In nominal and ordinal, you cannot do any arithmetic. Even if you add male and female, for that identity does not mean anything. So interval and ratio are called quantitative data. And anytime you have interval and ratio data, it's telling you that your data can be measured in quantitative way, and you can use you can use parametric analysis. When we get there, I will explain further. So it's telling you indirectly that interval and ratio, your data is somehow normally distributed. Well, if you have nominal and ordinal, that is qualitative data, and most cases, that sort type of data is not normally distributed. So in statistics, generally, we have two types of statistics. We have descriptive statistics and inferential statistics. And descriptive statistics is the one that you just describe, you just give information. You just give information about certain population or certain data. And in most cases, descriptive statistics is what policymakers or what people want to hear. If there is outbreak of diseases in a particular environment, the policy or people want to hear how many people have contracted that particular condition, and how many people had that disease, how many people that died, how many that are hospitalized. So these are descriptives. You are just describing that particular data. Well, another type, inferential, you now give impressed. You are trying to analyze the data. So in most cases, if you have cross-sectional studies, you use descriptive statistics to analyze it. If you have experimental, you use both, because sometimes you describe the data, you use both descriptive and inferential statistics to analyze your data. So in most cases, as I said, policymakers, they are more interested in descriptive statistics. Well, most of scientists, they are interested in inferential statistics. They want to see what inference do you come out from your analysis, or which intervention is most effective and which one is not effective. So we're going to see this type of analysis. And you remember I said your analysis depends on the design, because your design can be can be descriptive design or can be experimental design. So also that determine your data analysis. And I said it's also depend on the aim. What do you want to compare one group to another, or do you want to just describe your data? Also that, and the type of data, the one that I explained now, nominal, ordinal, yeah, interval, and ratio. So this also determine which type of analysis that you are. As I said, the last two, interval and ratio, they are called quantitative data. The first one, ordinal and nominal, they are called qualitative data. And that will also help you to know which type of analysis you are going to use. And I said, basically, we have two types of analysis. I couldn't put the descriptives on the screen. I said descriptive and inferential statistics. And I said descriptives is the one policymakers are interested, and it involve mean, median, mode, standard deviation, and this mean, median, modes, they are called measure of central tendencies. Then we have measure of dispersions, that is the standard deviation and interquartile range. And this is not that any data that you have your measurement in ordinal and nominal. And if you want to do measure of central tendency, you don't give mean and standard deviation. You only give median or modes of that particular data. Then if your data is measured in ordinal and ratio, you give your measure of central tendency, you give mean or average. And measure of dispersion, you give standard deviation. The measure of dispersion for qualitative data is you give interquartile range. So not all data that you do standard mean and standard deviation, depending on your level of measurement. And this, for descriptive data, what you describe is measure of central tendency. And I say this measure of central tendencies, they are mean, median, and mode, and average. A measure of dispersion, they are standard deviation and interquartile range. So these are called descriptive analysis. And in inferential statistics, inferential is divided into two, and is the one, anytime you have hypothesis in your research, you must do inferential statistics. And this inferential statistics is divided into two, non-parametrics and parametric analysis. And you can see from the screen, if you have nominal data, you do non-parametric. If you have ordinal, you do non-parametric. So these are called qualitative data. So if you have qualitative data, you do non-parametric. If you have quantitative data, that is ratio and interval, you do parametric. We assume that the data is normally distributed. So what is parametric? Parametric is the analysis is an inferential statistics that requires I think I have explained, but let me come back. What is inferential? Inferential statistics that allowed you to test for your hypothesis. And I said it's divided into two, parametric and non-parametric. What is parametric analysis? Parametric analysis is the type of analysis that requires certain assumptions. So it's require your data to satisfy some certain assumption. Well, non-parametric analysis does not require your data to satisfy any assumption. And in other words, it's called assumption-free analysis. So if your data does not satisfy the assumption, you have an alternative way to analyze it. You just go for what? Parametric analysis, non-parametric. If it satisfies some assumption, then you go for parametric analysis. So the difference between the two is, one, your data must to satisfy certain assumption, that is parametric. Non-parametric, your data does not require to satisfy any assumption. So as I said, this is exam. I think I explained all this. You describe, you summarize. help you to understand the population, guide you in research, policy makers, clinic, and so on. I said this descriptives, they are mean, standard deviation, median, interquartile range, mode, graphic, budget, and pitched. They are all called measure of central tendency and measure of dispersions. So if your data measured in ordinal and nominal, you do median and interquartile range. Your data measured in interval and ratio, mean and standard deviation. So if your data is quantitative, you do mean, standard deviation. If your data is qualitative, you do median and interquartile range. And so this is what we use for descriptives. Inferential statistics. In inferential, if you are comparing two sets of data, that is pre and post, you have a data pre and post, you do a pair t-test, you do a t-test analysis, what we call student t-test. There is no time to explain. We may take the whole day if we are to do all this, but we are trying to give a summary of all this. So if you are comparing two sets of data, that is, you measure data in a class. Let's say in this workshop, I take initial data before I started this lecture. I will give you a test about quantitative research and the statistics. I now measured, give you a test and mark it. That is pre. Then after this lecture, I give you another test. I now mark it. So I want to compare performance pre-lecture and post-lecture. Then that is comparing two sets of data. Then we'll do a t-test. And t-test, we have two types of t-test, pair t-test, what we call dependent t-test, or unpaired t-test, independent t-test. So in this case that I gave you this example, we'll do a pair t-test. Then that is what we call t-test, the parametric analysis. Then equivalent non-parametric, which will cause in sign rank test, is the equivalent non-parametric analysis for pair or dependent t-test. Then if you have two sets of group of data, let's say we have two groups of data, group A and group B, and we want to compare them, do what we call independent or unpaired tests. And independent t-test, that is parametric analysis, is also called unpaired t-test. And its equivalent non-parametrics is Mann-Whitney U-test. If we want to compare, that's the equivalent non-parametric analysis. Then if you have three sets of data that you want to analyze, the like example I gave for the test, pre-test, post-test, and you also measure after some time, you have three sets of data. Then you do repeated measure ANOVA, one way repeated comparing. Sorry, if you are comparing three or more groups, you do one way ANOVA. An equivalent non-parametric is Kruskal-Wallis test. If you have more than two groups, then if you have more than three sets of data, you do repeated measure ANOVA. An example is one-way repeated measure ANOVA. And example of non-parametric, the one I gave, one-way analysis is example of parametric. Example of non-parametric is non-parametric example is a Friedman ANOVA. That's the example of non-parametric analysis. If you are testing for relationship or that is association between one variable, the parametric test is Pearson. If you are testing relationship between one variable or the other, the non-equivalent parametric is Spearman-Rowe correlation co-analysis. That is non-parametrics equivalent. And other non-parametric analysis that doesn't have equivalent in parametrics are chi-square tests. They are non-parametrics. It's a popular non-parametric analysis and does not have equivalent in parametric analysis. And others are sign rank tests. They don't have equivalent in non-parametric analysis. So I hope this few, just I'm trying to summarize the statistics. I hope you are able to get one or two things from it. It's help you in taking your data analysis. I said anytime you want to do a data analysis, the first thing you consider is your aim of your study, the design of your study. If the aim is you want to compare, that will also guide you on the type of analysis you want to do. If the aim is just to describe, it will also help you on the type. Then the design, if you are doing experimental, you should know that you do descriptives and inferential statistics. If you are doing descriptives design, you know that you only describe your data. You don't need inferential statistics. And if anytime you have hypothesis, you should know that you must do an inferential statistics to analyze your data. So thank you very much. If you have any questions, also part of it is you need a data, your type of data, nominal, ordinal, interval, and ratio is very important in knowing whether you are doing parametric or non-parametric analysis. It will just give you a guide. Before you test for normality, you can go ahead and test for normality. But before doing that, anytime I know that my measurement is on interval or ratio, I know the type of analysis I'm going to do. So thank you. Any question? I have some exercise for you that may see whether you have really understand this things. So thank you very much for listening. Any questions? Any question, please?
No question, sir.
No questions? Hope you understand. So can you answer number one, the relationship between body mass index and peak expiratory flow rate? Which type of analysis will you do? How many patients suffer from stroke? Which type of analysis will you do? So you can take this, or if you have any questions, you can ask. Any question on data analysis, please? Yeah, I came on. I came on. Yeah, Dr. Ku, I'm done if there is no question.
Okay.
But let me see, I saw some messages here.
Okay, no problem. I don't know whether Dr. Isa is ready. I don't know how ready he is. Going Kirashi.
Kirashi Kaji.
Okay, we're in Kirashi.
Until 1 o'clock. Good afternoon, everyone. Dr. Yakubu, can you unshare can Dr. Kaka stop sharing so that I can share my slide? Yakubu, are you there? You either place it on multiple sharing or the sharing of Dr. Kaka can, I mean, Professor Kaka can stop so that I can share my slides. Am I audible?
Yes, Ma, you are.
So I'm saying is Professor Kaka online? He's still sharing his slide.
Matsalan yana duba yana nuna yadda take yana nuna mosquito ne. Now? Now? Bama, it does, Bama. Kai. Kai.
Afternoon.
Good afternoon. We can hear, sir.
All right. Yes, is my slide visible?
Yes, Samuel, you can put it on full screen.
Put it on slideshow. Thank you.
All right.
You can make it a slideshow.
All
To
right.
make it.
Just give me a minute for that. Okay, am I audible? Hello? Am I audible?
Yes, sir, you are.
So can we start right now? We can start, right?
Yes.
This section is about qualitative research, and it's basically an introduction to it. So some details may not be necessarily available, but I believe that at the end of this session, you have a know-how about what is the content of a qualitative research. Now, qualitative research is an interdisciplinary, transdisciplinary, as sometimes counter-disciplinary field. What this is trying to say is that you have multiple areas where qualitative research is actually applicable. And as we move on into this presentation, you're going to understand some of these areas where we apply qualitative research. At the same time, one of the things that I need to make clear is that in health sciences, of recent, one of the areas that is in vogue when it comes to research is qualitative research. There are quite a number of countries that they factor in qualitative research a lot into literally every content of a quantitative research. But the commonest form of research that we do in Nigeria is essentially the quantitative, where you are expecting yourself to do to bring in a number of statistical jargons to interpret your findings. But in qualitative, as we move forward, you understand how do we do the analysis, what is the main content of a qualitative research. Qualitative research crosses the humanities and the social science and physical sciences, including medicine, health sciences, and all that. Qualitative research is many things at the same time. And what this is trying to say is that you have a number of things that you bring in when it comes to qualitative research. And the interesting thing about it is sometimes even transformative. And what I mean here is that you can actually transform your qualitative to become quantitative at a particular stage. And you make interpretation subsequently. You can invite some statistical jargons into it. But then mainly, it touches diverse areas when it comes to the details of qualitative research. It is multi-paradigmatic in focus. The paradigm era in which we find qualitative research is multitude. And that's why in the previous sentence where I talked about it's being applicable to social, physical, and physical sciences, and as well as humanities. Its practitioners are sensitive to the value of multi-method approach. Um, Individuals who are involved in qualitative research, they are conscious of the need for multi-method. And when we talk about multi-method approach of study, it's not the usual mixed method where you have quantitative and qualitative. It is a situation where you have multitude of research designs put together in order to conduct a particular finding. They are committed to the naturalistic perspective and to the interpretive understanding of human experience. Qualitative research is essentially situational in the sense that it interprets the event of the moment, the natural situation of a people, their understanding, their expression, their perspective of looking at issues. So this is what qualitative research does essentially. At the same time, the field is inherently political and shaped by multiple ethical and political positions. In this particular area, when we talk about the political perspective of qualitative research, it's not a huge, it could be the usual political issues, but then it creates a lot of debate among people. That's what makes it a lot political.
It's very argumentative. It creates a diverse view of people. It brings it together and interprets it and makes sense out of their diverse views of a particular situation. Qualitative research involves finding out what people think, how they feel, or at any rate, what they think, and how they say they feel. This kind of information is subjective. It involves feelings and impressions rather than numbers. So the key thing about qualitative research is that it's about what is the perspective of a people about a particular topic, a particular situation. So what do they feel about it? What is how do they interpret it? What does it mean to them? So when we talk about qualitative research, this is the major focus. It's about you saying it in your own way. It's about you expressing yourself. It's about you interpreting it in your own perspective. It's just like the common saying that when you write the number 6, somebody can stay on the other side and say this is actually 9, not 6. So it's about that. It's about people. How do they look at situation? How do they interpret it? What is the impression they have about something? Let's take, for example, during COVID-19, the general thing is that people are scared, people are worried, people don't even know how to handle the situation. But at the same time, while some people believe that it's actually there is something known as COVID, we have a number of people that actually have a feeling that there is nothing not known as COVID, and in fact, let's say it's just a conspiracy issue. Some people have a feeling that it's actually not natural, it's actually manufactured. It is created to destroy a certain group of people. It is meant for Africa, it's for elimination and all that. Those kind of perspective, what do people feel about a situation, an ongoing situation, a created situation, and whatever it is? Qualitative research is an interdisciplinary, transdisciplinary, and sometimes I think we've seen this. Okay, qualitative research is multi-method in focus. Um, uh, it's multi-method in the sense that the approaches to it are diverse, even though it is not itself a multi-method technique of research, but it involves diverse areas of focus of people. So that's why they consider it as being multi-focus. It involves both interpretive, naturalistic approach to its subject. So these are the key approaches, either interpretive or naturalistic approach. Qualitative researchers study things, people, and their thoughts in their natural settings, attempting to make sense or interpret phenomena in terms of the meaning people bring to them. What meaning do people attach to a particular situation? How do they define it? What do they feel about it? Let's take the common debate now about the tax situation that the government in the Tinubu government is bringing in. While some people, if you look at it, we have two dimensions. Probably the people in the South have a feeling that I think this is okay. This is about people that are making production to have everything belonging to them. Some people say that even though we are consumers, but you relied on us to be able to sell your product, and for this reason, we think you are making this to be a disadvantage to us. So you see, these are two different perspectives. We are manufacturers, and therefore, since we are manufacturers, we should earn the bigger chunk of it. Somebody now say that, yes, I agree you manufactured it. Keep it in your house, and let's see whether it's going to be meaningful to you. You need me. I need to consume it before you can sell it. If I don't consume it, it's a waste. So therefore, if we're talking about sharing, then it should be meaningful in the sharing. This is just a typical perspective of saying, oh, this is the way we view it. This is where we view it. And so many other interpretations when people are asked about the tax. I think the North are being lazy. I think the South are being selfish. These are just feelings. How do people feel about a situation, and how do they interpret it? What perspective? How do they look at it? What is their impression about it? This is what qualitative research is basically talking about. Qualitative research involves the studied use and collection of variety of empirical materials, case study, personal experience, introspective, life story, interview. Now, what I want you to understand in this area is that even though it is empirical, it involves the use of empirical material. The empirical evidence here is not actually objective one, it's essentially subjective in the sense that is the expression of a people that you are putting together to be able to make sense of their expressions, and it is still considered being empirical enough because it is based on evidence, is based on what they say. The evidence you have is that this is what they say, this is the way they view it, and therefore I'm going to explain it in that regard. It also have an observational aspect where you observe and interpret situation. It is historical. You can gather information historically and also interpret it. It is interactional. It could be how do people interact, how do situations interact with each other or one another or multiple different situations. And visual text that describe routine and problematic moments and meanings individuals or in individuals' lives. So of course, you look at problems, you look at situations, and how do they mean, what difference do they make in the life of different people? So you put all this together, you can approach qualitative, and that's why they talk about the issue of being multi-method. You can see we have, it could be case study, it could be personal experience, it could be introspective, life story, it could be interview, observational, historical, interactional, visual text, and so on. So all these, you can approach qualitative research from these diverse angles and make sense and bring out information that will actually interpret the situation you are trying to address. It deploys a wide range of interconnected methods, hoping always to get a better fix on the subject matter at hand. So, like I said, you approach it from different angles and pull this information together, and your target is actually to get to fix the situation you are trying to interpret or address. The qualitative researcher is sometimes looked at as a bricklayer. Now, when we talk about a bricklayer, we referring to somebody who actually pulled so many things together and construct something out of it. So it's like somebody who is a jack of all trades. A jack of all trades or kind of professional do-it-yourself person, DIY. Somebody who feels that I can put many things together and do it myself. So he pinches from here, he pitches from there, he pitches from different angles, pull the information and construct something meaningful out of it. And a number of researchers actually look at qualitative research as the baseline research, which try to explore circumstance, define a theory out of it, so that those in quantitative research would take the theory and conduct a let's say an experiment or a research on that theory to confirm the existence of the theory. So the background of a number of others of studies is actually the exploratory aspect, which often comes from the qualitative research. Explore the situation, define the situation based on your findings, and create a theory out of it. I'm assuming, I think something like this. I'm suggesting. So how did you come about the suggestion? It's actually based on the information you've gathered, and therefore on this information you are trying to say, what if, and what if? So these what ifs that you're putting together, you now have a group of people that will look at these what ifs and now come up with an experiment to prove your what if. And at the end of the day, we now have the combination of the qualitative and the quantitative giving us a sense out of whatever situation you're actually trying to define. it actually produces a bricolage that is a piece together, bringing pieces together. It closely knits set of practices that provide solution to a problem in a concrete situation. So this one of the things that, like I said earlier, you pull different situation together. Like for example, when I talk about issues of how do people view a particular thing. Now, the government is trying to address the tax situation in the country, and now they can, instead of being, let's say, authoritative or acting as authoritarians, they can say, okay, let's look at the argument of these people. What do they have? Let's take the expression of the people on the streets. Let's take the educated ones, the middle class. Let's look at different parts of the country. What is their view about this? And let us bring these pieces together as a bricolage. Bring these pieces together, interpret the information, and at the end of the day, arrive at the decision that the government is going to take about the tax situation. So bringing this perspective, different pieces of information together in order to make sense of it, and at the end of the day, be able to determine what the government is going to do or what the researcher is going to do, is what we mean that a qualitative researcher is actually a bricklayer. The situation which is, the solution which is a result of bricoleurs method is an emergent construction that changes and takes new forms as different tools, methods, techniques are added to the puzzle. The puzzle is actually the research you want to conduct. So now you pick different pieces of approaching it from using different tools, using different approaches, using different techniques, and at the end, you're trying to address the subject the subject of your research. The qualitative researcher, as a bricklayer, uses the tools of his methodological trade. What methodology is the researcher going to use in order to solve the situation he's trying to address? The choice of the researcher, the choice of the research practices depend upon the questions that are asked. What questions? What actually is the particular question that the researcher intends to ask? Now, in this, for those who attended one of the classes I conducted on quantitative research, immediately you come up with your statement of the problem which you intend to address. You need to ask specific questions. Then after it, you determine the objectives you have. In qualitative research, we do not usually into hypotheses. So our major area is, what are the questions? What are the objectives the researcher intend to actually achieve? So the choice of research practices depend upon the questions. So am I going to use a focus group? Am I going to use an in-depth analysis? In-depth interview and all that. So what approach are you going to put to give the question? The type of question you ask is what determines how do you go out there and collect your data. And the questions depend on their context. What is the context in which you are asking this question? So the context also, to develop a question, you look at the context itself. What is available in the context and what the researcher can do in that setting. So the question also depends on the setting. In which area are you conducting the study? Let me give you an example. I recall previously, when you are conducting a research in a community about, let's say, issues related to women, there are questions that if you ask somebody, it is actually insultive when you are asking somebody from the East. When you are asking somebody from the Southeast, probably it is insultive to say certain things to women. But then probably that same statement you made is like you are praising someone in Southwest. And probably nobody look at it as a big deal when it comes to the North. For example, in the North, if we If somebody is a leper and and he has a son and his name is, let's say, Abubakar. If I say, oh, yesterday, you see, we actually met with Abubakar, and you say, oh, which of the Abubakar? And I say, oh, the son of the leper. Nobody actually look at it as you are doing anything wrong. But can you actually say you are describing John and you say John, the son of the leper in the north and the south, either southeast or the southwest? It's completely unacceptable. So the setting actually determines how you set the question. So what type of a question do you set when you are in a particular setting? What is the context of the question? For example, if you say to somebody, madam, if you say madam, if you are in Cameroon and you say a madam, you are actually praising a lady. It's like an honor to a lady for her to be known as a madam. Call any Nigerian lady madam. It's like you are condemning her, you are telling her she's old. So the setting actually determines how do we set the questions, what is the context, and how do we bring out the type of question we ask in a research, particularly when we talk about qualitative research. The bricklayer is adept at performing a large number of diverse tasks, ranging from interviewing to observing to interpreting personal and historical documents to intensive self-reflection and introspection. So this is the diverse work of a researcher who is a qualitative researcher. He brings in all these approaches in order to make sense of the question he's trying to ask in a research. As a bricklayer understands the research is an interactive process shaped by its own personal history, biography, gender, social class, race, and ethnicity, and those of the people in the setting. So in qualitative research, one of the things that is very difficult for you to separate is the perspectives of the researcher being involved in the research. While in quantitative research, we are always trying to avoid the context of bias. Unfortunately, in qualitative research, the bias, the sentiment of the researcher sometimes goes into the research. And it does not invalidate the research. Because just like when you talk about, let's say, somebody who conducted an exercise, participated in an exercise for weight reduction. If you say a physiotherapist should actually interpret the findings, he probably will be concentrating on what is the weight of that individual, what was the percent body fat, what is the waist circumference, what is the hip circumference. He's basically going to go on anthropometric assessment. But when you come to the perspective of a physiologist, he will be interested in the typical physiological changes that the individual will be having. So you can see these are different approaches. From the perspective of the researcher, they approach it in different ways. In my own, these are the specific parameters that are important. In the other researcher, these are the specific parameters that are important. So they interpret it according to their field. But then in qualitative, some certain aspects of the life of the researcher may actually have some impact on the way he approaches the question, on the way he's going to ask the question, on the way he's going to approach the participant. So, and the setting also, the place where this study is being conducted also has a number of influence on what question do we ask, what approach do we give, and so on and so forth. Let me give you an example. There was this time I was conducting a class of massage in South Africa for undergraduate students. Here in Nigeria, I take the same course, massage, but then whenever we are going to do our practical session, I often ask the male to be on one side and the female to be on the other side. And the male subjects, I'm going to have a model among them. And the female, I'll beg one of the males to be the subject to the females. And this we find it a lot comfortable, particularly because I'm actually teaching in the North. So looking at the particular scenario I find myself, it is a lot easier for me to ask the male subject to expose their body part when we want to do our practical sessions. But I cannot, it's literally impossible for me to say a female student should expose certain parts of her body when we want to do a massage practical. For example, expose your back for us to do skin rolling. This will be difficult, particularly here in the North. I wouldn't say what happens in the South, which I think is about the same thing because of Nigeria. Now, in South Africa, when I wanted to do the same kind of class, and I said tomorrow we are going to be having practical, and I was describing to the male, this is the way I want you to dress. What is interesting is that all my ladies actually dress the same way the following day. And when I say who is going to be our subject today for this for this session, a lady quickly jumped on the couch and we started our practical session. This is literally impossible in Nigeria. So the setting itself has a way of defining how we relate and how we pose a question, how we create the question, and all that. So the perspective of the researcher is an important area, and the perspective of the setting and the participant is also very key when it comes to qualitative research. The product of the baccalaureate level is a brocolage, that is a pull together of different ideas, a complex, dense, reflexive, college-like creation that represent the researcher's images, understanding, and interpretation of the world or phenomenon under analysis. So the bricolage that the researcher pulled together, or let's say the entire outcome that the researcher is going to give us, is actually going to be part of it will be the reflexive aspect of the researcher, the dense thought of the researcher, the college-like creation of the researcher. It actually represents what image, in what way is the researcher looking at the finding. What is interesting about a qualitative research is that you're going to have a transcript, and this transcript, when somebody read it, he has a way he perceived the transcript. When somebody else is going to look at that same transcript, he has a different way of interpreting it. So in a way, you have a lot of the involvement of the perspective of the researcher in interpreting findings of a qualitative research. It is unlike quantitative research where everything is completely objective and the control of the researcher over the findings is actually limited. But to a large extent, qualitative research is the findings of a qualitative research, or the outcome of qualitative research has a lot to do with what is the perspective of the researcher, what is the view of the researcher about the transcript being generated. The bricolage will connect the parts to the whole, stressing the meaningful relationship that operate in the situations and social world being studied. Now, in trying to talk about qualitative research, there are diverse areas. So we're going to be looking at number one, which is the positivist paradigm. It emphasizes that human reason is supreme and that there is a single objective truth that can be discovered by science. It encourages us to stress the function of the objects, celebrate technology, and to regard the world as a rational, ordered place with a clearly defined past, present, and future. So what we say about that is that the view of the positivist is that there is more or less like a unidirectional view, that there is a supreme thing. There is this perspective that is the most important, and there is a single objective. The direction of everything is tailored towards one single objective truth. And what science is trying to do is to discover this truth and bring it out for people to view. So there is a direction, that is a perspective that is always targeting what is more accurate, what is more genuine, what is more truthful, and presenting it in that direction. That's the view of the positivist. And like I said, it encourages us to stress the function of objects, celebrate technology, and to regard the world as a rationality, and an ordered place with a clearly defined past, present, and future. So the direction is known, and it is actually unidirectional. So what of the non-positivists? They actually question the assumptions of the positivists. They actually, so the clear, we understood the clear, the assumptions of the positivists that everything has a direction, and it's either, basically, we are trying, when it comes to disease situation, we say, are we trying to prevent? Are we trying to cure? Are we trying to rehabilitate? So direction is known. But the non-positivists actually feel that it is not just like that. There could be diverse areas of looking at situation. It's not always straight. You can't always say that everything is going in a linear position. There are some curves as you move. It's just like you saying, let me get to my office, as you're seated and you realize that you're at home, and now when you want to go to your office, therefore every building that is on the way, because you want to make sure that everything is in a linear direction, you have to break your wall because everything has to be straight. You have to break every car that is on the road, crush it, everything. You just mark to make sure that the direction is just one. So a non-positivist says to you now, no, there are diverse ways of looking at issues. It is not as easy as the positivists actually view it. It argues that our society places too much emphasis on science and technology. So it is not anything, it's not everything that has to be science defined. There are things that can never be defined by science. For example, who is God? How do you prove the existence of God? Science now has no typicality of a way to say that I'm entering the laboratory, I'm trying to define that based on laboratory findings, this is what it defines God. And again, you now have different ways of people interpreting God. What is prayer? How do science define prayer? What is the impact of prayer scientifically? So this is completely a social paradigm, and it cannot easily be defined by science and say that scientifically this is how to define God, scientifically this is how to define prayer. Does it even make sense to pray in science and all that? So you see, there are diverse areas of looking at issues based on non-positivist paradigm. It argues that this ordered, rational view of consumers denies the complexity of the social and cultural world we live. Now, for you to always assume that something has to be rational, it actually denies the complexity of our social interaction, our cultural perspective of looking at issues. For example, when you say how does the culture of a people, for example, when we say what is quality of life, the quality of life of a people, for example, when you say, or probably you say, what is food? What do you consider a food? I recall when I was doing my NYSC, a colleague of mine who was also a core member actually came to my room and said that, what is wrong with you? I've never seen you eating gari. I've never seen you taking this gari, what is it? Eba. I've never seen you either drinking it or whatever. Why are you not taking gari? And for me, I was like, what is so important about gari that somebody has to ask me about gari? In where I was coming from, when you see somebody taking gari, is because the poverty level is so magnificent that it's so bad. It has become so bad that that individual is eating gari. But here is someone who is having a different view and saying that you are not taking gari. Are you really well? Is something wrong with you that you don't take gari? Why? Culturally, for him, gari is an important meal that should never be absent in the life of an individual. But from where I'm coming from, socially, culturally, gari is not that important. Now, it's just the same thing when I say, why are you not taking what we call tuwo in the north, which is the bolus form of making what do you call it? This starch that you put together to make tuwo from maize. and what do you call it? And I'm saying, why are you not taking po? And I'm asking an Igbo man, why are you not taking that? He will be like, how is that important to me? But deny him Gary, and he feels that, why are you being wicked? So the perspective, this perspective of human perspective and social and cultural lifestyle, it's not necessarily rational. It's not necessarily rational. It's not necessarily scientific. But then this is who they are, and this is how they view things. This is their nutritional way of life. And somebody is now saying it has to be scientifically, everything has to be calculated, whether this has to go in this direction or not. This is not how the non-positivists actually have a feeling that if you go from positive paradigm, you are not allowing the social and cultural perspective of a people to define situation. It stresses the importance of symbolic, subjective experience. So non-positivists look at the symbolic aspect, the subjective aspects of people's life, and let them express it. So it's not necessarily going to be consistently, everything has to be objectively defined. The subjective aspect of life has to be reflected. So there are these 5 moments of qualitative research I would like us to share. Let's look at the traditional period between in the 90s, World War II. Okay, here is a narration of something that was written on the objective of colonizing account of field experiences that were reflective of the positivist scientific paradigm. It was concerned with offering valid, reliable, and objective interpretation in their writings. The subjects who were studies was alien, foreign, and strange. So the subjects that were studied in this particular research, the focus was they wrote it with an objective of what is the field experiences of a people. How do they reflect the situation? So when you look at these particular expression, how are you expecting us to be able to define the situation when we are tell us your field experience? And when we now say tell us your field experience, we are now saying that we want to interpret the field experience through scientific, rational, and whatever way. Now, while this individual is actually telling you his own life story, how do you now look at it? That what is the validity of the information? How reliable is the information? What is the objective interpretation of what the individual is telling you? How do you do that? So you realize that it's literally impossible for you to be able to do that, except if you are going to just take the expression of that individual and the personal account of how he, the situation and the experiences he gathered in the field. So this will literally, it's literally impossible for you to be able to define this scientifically. So the modernist space, post-war, 1970s, the modernist ethnographer and sociological participant observer attempted rigorous qualitative studies of important social processes, including social control in the classroom and society. Researchers were drawn to qualitative research because it allowed them to give a voice to society's underclass. So here, what we are trying to say is that around the 70s, we now have people who look at, we have got a bit of improvement. That was World War II, and now we're looking at field experiences. Now people have started looking at the ethnographic situation. When we talk about ethnographic, the setting you find yourself and the context of the people in that area, how do they observe situation and how do they express it? In this situation, we are looking at both the upper class and lower class, but the major interest is that the underclass, how do they look at situation? For example, now in the north, where and probably I wouldn't know whether we have areas in the south where we have situation like that, and you wanted to know what is the perspective of the people in areas that are ravaged by banditry, and how they are able to run schools, how do the society function with the ravaging incidents of banditry, um, what is happening to the different social groups, and how are they able to handle their situation scientifically. I mean, let's say quantitatively, it will be difficult for you to be able to say you are going to take the expression of people and put it together. But then, I mean, to take it quantitatively and say that this is the quantity or whatever, you can do that. But then the life situation and how people express themselves will give you a better and more informative situation about what is ongoing in those areas. The blood then race. This actually exists between the 1970s and 1986. Researchers had a full complement of paradigms, methods, and strategies. Here, there is evolution of the different areas of uh, collating information regarding qualitative researches, and the methods are evolving, and people are beginning to understand that for us to make sense of qualitative information, we need to have this, we need have to have this method, we need to have different strategies of bringing the information clearer to people. The era actually applied qualitative research was gaining a lot of stature. It's becoming very relevant to interpreting situation and accepting it as a form of research method. In the previously, the major focus is that everything can only be scientifically defined. But now we are beginning to understand that there are different perspectives of looking at situation and defining the circumstance of a people, and can be also be considered as a form of research. And that era is between the ages of 70 to 86. That's when the shape of qualitative research started gaining advantages. Research strategy range from grounded theory to the case study methodologies. We're going to be looking at what do they mean by the grounded theory and all that as we move forward. Methods included qualitative interviewing, observational, visual, personal, and documentary methods. So these methodologies started evolving that to address a qualitative question, we can go for interviewing, we can observe, we can have a visual look, a visual outlook of the situation. We can look at it from personal perspective. We can also look at documents, and they can also satisfy our need for giving meaning to a question. Computations were becoming more prevalent, and in interpreting, and of course, different softwares are coming on board to assist in interpreting information regarding qualitative research. Boundaries between the social science and humanities had become blurred. So now there is a class of closing the gap between social sciences and humanities. To a large extent, you now have a situation where people don't even know the distinction between what the social scientists are doing, the humanities are doing, and including the health sciences. Now, some researchers, by the time you use qualitative research from A to Z of your research, some people just actually have a feeling that you are only giving stories. What is the research in this? What is the research in this? He's only telling us this one say that, this one say this one say that. At the end of the day, I think all of them are saying this. So people have a feeling that, did he really conduct this? What is he trying to say? So when you make interpretation, either from social science perspective, from humanities perspective, or from health sciences perspective, and it is actually qualitative, you literally cannot separate the three of them, either social science, either humanities, other physical science, or health sciences. You hardly can differentiate any one of them, because it is completely expressional. And aside from the fact that the subject matter the subject matter is the only thing that will differentiate. But primarily, the expressions are the same. There is nothing that is going to differentiate the expression. I'm interpreting what this person say. You are interpreting what a person say. So you see there is a closure of a gap between in all these scientific areas, on these specialized areas. Social science was borrowing models, theories, and methods of analysis from the humanities to interpret its own findings, and vice versa. Researcher acknowledged as being part of the research process. Like I said earlier, the researcher in qualitative research is actually being part of the research process from the beginning to the end. You cannot dissociate the participation of the researcher from the main content of the research, particularly in qualitative research, unlike what we have in the quantitative research. For those who attended one of the classes we presented on quantitative research, where we are talking about blinding, you blind no one. There is nobody that is going to be a blind person to any perspective of the research when it comes to qualitative research. So everybody is aware of what is going on, and we carry on with the research. Crisis of representation. I want to beg you if I could jump these areas. They are not that very important. This presentation, they are just historical, and I think we can go to something more meaningful. Okay, now let's look at what is the distinction between quantitative and qualitative research. Now, in qualitative research, the first area we want to look at, what is the type of question? What is the sample size? What information are we expecting from respondents? How are the two administered? What type of analysis do we conduct? What is the type of research that we actually expect to do in these two different research approaches? When it comes to type of questions, literally most of the things we do in qualitative research, we probe, we keep asking, we go deep in trying to query situation, in trying to find out situation, and we keep trying to dig deep. That's what we do in qualitative research. But when it comes to quantitative research, we have limited probing because we use tools. Even if it is a questionnaire you're using, provided it's a closed-ended questionnaire, you realize that you have limited chance for the participant to express themselves. So there is no expression. It's about completely under control. You have a signal level of control over the information you are trying to generate when it comes to quantitative. But then in the case of qualitative, we do not control the information. We allow it to flow. So what of the sample size? The sample size in qualitative research is usually very small, but when it comes to the quantitative research, they are usually large sample size. Also, why do we have to have small sample size in qualitative research and large sample in the case of quantitative research? In qualitative research, what determines your sample size is the response of the respondents. How are they responding? If I recruited, let's say, 20 people to participate in a study, and I was asking them their perception about the tax situation in Nigeria and the attempt of the government to change the tax situation. And part of those people the people I decided to recruit, I decided to be a bit diverse in trying to recruit people. Now I decided to get the academics, I get the clinicians, I get the roadside mechanic, I get the let's say different artisans, and all of them I put them together to respond to my question about what do they think about the tax the government is about to introduce. Now here I am expecting them to respond to my question, and they start telling me stories. This is what I think. This is what I think. This is what I think. And this is my perspective about it. This is my impression about it. This is what I think is going to happen to me. This is what I think is the future of the country. And then people try to continue to say their own belief about the question. Now, at the end of the day, I now came to a level where what people are saying remain consistently the same.
The Khalifa is if the Khalifa do, you must print it now.
Sorry? Can you mute yourself, please? Okay. So what the people I recruited are saying remain consistently the same after I interviewed, like, let's say 15 of them. I realized the 14th person was saying literally what I've had, and the 15% also repeated what I've had, and the 17% repeated what I had. Would there be any need? Would there be any need for me to continue probing? Since I don't know who is there. Somebody is Can people mute themselves so that we can continue with this? So like I said, when I continue to probe and I reach the 14th person, and the question I ask, he is repeating one of the things that the initial 13 actually mentioned. And I also probe the 15th person, and he's saying one of those things that I've already listened to. And I go to the 17th person, no one is going out of what I've already gathered as information. There will be no need for me to continue asking the same question because the responses remain consistently the same. So at that point, I have to stop my recruitment of subject. And that is what they call the point of saturation. So the information I'm getting are the same. So I've reached what they call the point of saturation. So with that, I've closed the chapter of the number of sample size. But in the case of quantitative, there is no such closure. I need to get as much information as possible because I have limited probing, and I have a direction of the study, and my outcome measures are clearly defined, and therefore, as much population I get, as more I actually have more chances of generalizing my findings. The perspective of qualitative research is never intended towards generalizability. You don't intend that the findings of this study is going to be generalized across the population. But in the case of quantitative, the intent, one of the major intent of quantitative is for us to generalize our findings. So therefore, for us to be able to generalize our finding, we need a representative sample that will be able that we can use, that when we get our information, we can generalize to the extent, the larger population. So what is the information that we need per respondent when it comes to qualitative? We need a lot of information. We need them to express themselves as much as possible. We need them to be as expressive as possible, as wide as possible, as in-depth as possible, as deep as possible in expressing themselves. But when it comes to quantitative, we need there are diverse ways of looking at it, and therefore it's actually restricted, and therefore there is no much information required from the respondent or from the participant. So sometimes we even have limited interaction with the participant, because just tell me this about you using this questionnaire. Immediately he responds to the questionnaire. I may not even see him at all. But in the case of qualitative, in most cases, even if I'm doing it virtually, there is a communication between the researcher and the individual. It is not always necessary for the researcher to have a direct communication with the individual when it comes to quantitative. So we're not saying that in qualitative there must always direct communication, but then to a large extent there is more contact, more chances of interaction in qualitative than it is with quantitative. How are they administered? It's actually in qualitative, you actually need skilled researchers to be able to conduct it. In the case of quantitative, we're not saying that we don't need skilled researchers, but basically it requires fewer specialist skills required also, but then in most cases, you even realize that we have to train them to be able to collect the data we are looking for. So in administration, you need classically skilled researchers for every qualitative study, where fewer were required in the case of quantitative. Type of analysis, often the analysis here is subjective and interpretive, while generally, when it comes to quantitative research, the analysis are statistical. One of the type of research is usually exploratory when it comes to what do you call it, qualitative. But in the case of quantitative, is actually descriptive or causal comparative analysis. These are some of the differences. There are quite a number of other differences. What of the popularity of qualitative research? Usually much cheaper than quantitative, actually, in most, because even from the subject sample size, you have limited sample size. So it's already telling you that it's a lot cheaper to conduct than the quantitative. And at the same time, you do not often have objective tools to assess anything. And some of these objective tools could be very, very expensive in quantitative research. Number two, no better way than qualitative research to understand in depth the motivations and feelings of consumers. If you want to know how do people perceive physiotherapy treatment for women, for pregnant women, you decided to do this. How do we know how pregnant women perceive pregnancy? Antenatal physiotherapy. So to understand their feelings, to understand their expression, to go deep in understanding what they feel, it will be better for us to go qualitatively than for us to. What is their misgivings when it comes to participating in antenatal exercise? What do they feel? What do they think are the motivating factors for them to participate in that antenatal exercises or antenatal physiotherapy? What do they feel? What do they think about it? What are the things that motivate them to participate? What are the facilitators? What are the barriers to participation in antenatal pregnancy? Antenatal physiotherapy. So these are things that it would be better to get the deeper feelings of our consumers, which are the pregnant women in this case. It would be better if we approach it from qualitative aspect of research. Qualitative research can improve the efficiency and effectiveness of quantitative research. This is very, very important, and I like this statement. Sometimes when you do a quantitative research, and you actually finish the research and you present to us, this is it. Sometimes we wonder, what do your patient actually feel about what you administered? You conducted an exercise program and you came out to say it was significant. But then, what if this exercise, even though you found a significant findings, but then it's telling us that patients are completely uncomfortable with the exercise? How do we know whether they are comfortable with the exercise or not? How do we know whether the exercise program you created is actually acceptable to the patient or not? How do we know about that? So we need to probe the patient and let them tell us how they feel about the exercise program you created, the model you are presenting. How do they feel about it? Do they have suggestion of how to improve the quality of their activity? Or what would they say? Would they actually be interested in asking others to join the program? And also on and so forth. Would they recommend this type of exercise to others that they will not recommend it? And let them tell us, why would they recommend it? Why do they think it is important? What benefit do they think the exercise has added to their life? How much do they think this exercise has improved their lifestyle and all that? How do we get this information? We can't get this until we go qualitatively, and which means if they are expressing to us that this is how much we feel this exercise, this is what we think this exercise has done to us, and now it is actually telling us how efficient the program has done, how effective, how much has it changed their life, and on and on and on. What are the limitations of qualitative research? And marketing successes and failures are based on small differences in the marketing fix. So sorry, I actually get this information from marketing field. So that's why you are seeing marketing on and on. Marketing successes and failures are based on small differences in the marketing mix. Qualitative research doesn't distinguish these differences as well as quantitative research can. Now, the thing is, if you have, if you, for example, administer, when the COVID-19 injection was manufactured and people were asked to go for it, now, at the end of the day, some people decided to take the COVID-19 vaccine, while some people were not interested, so they did not take it. Now, let's say the level of either protection, the level of, let's say, improved lifestyle and all that in these people was to be examined. We wanted to know how much those people who took the injection and those who did not take it, how has it transformed them in terms of performance, in terms of well-being and all that. Qualitative research cannot tell you how much improvement they've made. It cannot tell you the quantity, how better those people who are who took the injection are over those who did not take it. Qualitative data cannot do that. You can only do that quantitatively. If you have some outcome measures you wanted to measure to know whether lifestyle has improved or these people are doing better than the other group, there is no way you can assess that qualitatively. You have to do it quantitatively. So this is a limitation to qualitative research. It cannot give a difference between two different scenarios in a quantitative way that we can actually see based on measurement. This is better than this one. It's not representative of the population that is of interest to the researcher. So like I mentioned, the issue of generalizability, you cannot say that after getting qualitative information, it is not defining the perspective of the generality of the population. It's just a section, and particularly those people that you actually examine. So you cannot generalize and say that based on my qualitative findings, it indicates that all the people in this area accept that COVID-19 is not existing and so on. No. You can't do that. Quantitative research does not have the power of generalizability. So we cannot say it is representing the opinion of a diverse population. The multitude of individuals who without formal training profess to expert in the field. A number of people can claim that they are good in qualitative research. Meanwhile, they are not necessarily good in it. And because of this, it could actually, it's also one of the limitations of qualitative research. So you don't have situation to be able to understand when somebody is actually a true expert or not. So we're going to look at qualitative research as a process. Probably after this, we may close the chapter. Qualitative research as a process, it involves theory, method, analysis. All three interconnect to define the qualitative research process. The first thing is for people to have a thinking about a scenario, creating a theory around it, and for them to now, based on their thinking, and they just say that this is what we are assuming. So they create a method to confirm what they actually think. Let me say, for example, I think all people in the North do not like the tax, the intended tax formula of the government. I think all the people in the South actually believe this is the best thing to do. This is an assumption that I will need to actually verify. So when I create a method around the question, what I'm actually assuming, which is the theory I'm creating, to confirm whether this is actually the truth or not, the information I gathered at the end of the day, I will analyze this information and come up with the position that based on my findings, this is what I think about the people in the North regarding the tax, or the people in the South regarding the tax. I don't know, do we still have time? Or I take some few questions before we proceed? Am I audible?
Yes, sir, you are audible, sir.
Are there some few questions before we proceed? Because we're going a bit deeper now. Do we have some few questions? There are a few questions. Yeah, do we have some few questions that we need to attend to before we proceed? I think some arguments were there that some of the reasons for doing this CPDs is just for people to get points, and actually I don't want to be part of things like that. I would prefer a situation where I do give information and people can relate with what I'm doing. So, so do you want us to carry on? Do I just proceed if there are no questions for now? Yes, yes. You can unmute yourself.
Proceed.
Michael actually has a question, I think. Michael has a question. Can you unmute Mr. Michael Ogudamen?
Yes, I do have a question.
Yeah.
My name is Michael Ogudamen. I'm from Obasanjo Awolowo University Teaching Hospital.
All right.
I was wondering, when you were concluding, towards the end of the conclusion on this particular segment we're on now, you said qualitative research may not be generalizable to that extent because of the sample size that is being considered and
yes,
sought. But I was wondering if that statement in itself, is it not in itself a bit general? Because I understand there are some researches, though qualitative, that if it is taken up to the level of meta-analysis, would require, I think, can have properties of generalizability, almost to the same extent as quantitative research. Because I believe that the sample size that would have been considered, the various databases that would have been, included in the study, might give some power of generalizability, even though it's a qualitative research. I would like you to please shed more light on that. That was just my concern. I wanted.
Okay, thank you very much. I think I would like to explain what that means. In general, and I emphasize general, qualitative research as an entity for a particular approaching a particular question is not generalizable. However, when you have a pool of qualitative research, because there are what we call systematic review of qualitative research, or a meta-analysis of a qualitative research, which in this case is not a single qualitative research.
Exactly.
So then it has moved from that, it has changed the level of evidence.
Okay.
You understand? But as a single study on its own, it is not generalizable. I think this is, for those who are into research, they understand what I mean. Novice may not, but particularly you, I know definitely you understand what I mean here.
I do.
Right? So as a single form of a research, qualitative research cannot be generalized. However, when we now change the perspective of the qualitative research to push it to a form of systematic review, or we move towards doing a meta-analysis of the qualitative research, because we now have a pool of different researches together, and we are considering the entire population of the whole studies that we are pulling together, then the level of the sample size has changed, and the level of evidence has equally changed. So definitely in such situation, we can make generalization. I mean, we can generalize the findings. I don't know whether I've answered your question.
You have. Thank you very much.
Yeah. Thank you very much. So I think we can proceed from here, right? Okay. So we're going to be looking at different approaches of the qualitative research. We're starting with theoretical approach, which is deductive theoretical approach. It actually seeks to existing theory to shape the approach which you adopt to the qualitative research process and to aspect of data analysis. Now, I just hope that beginners will be able to relate with this. You actually have different approaches to conduct your research. And one of it is actually looking at it from theoretical perspective of the research. And to approach this, you have different stages. We have analytical process procedures. You analyze the theory itself, and in this analytical process, it's not that you are conducting any analysis, so to say, like somebody will be thinking that I want to go into what do you call it, statistics before I analyze the situation. It's about the way you interpret it and now develop the questions towards it. So that's what we mean the analytical procedures. Now, pattern of matching. It involves predicting a pattern of outcome based on theoretical propositions to explain what you expect to find. So when you have a situation at hand that you want to conduct a study on, you have to be able to predict the pattern of outcomes. Like I said, in qualitative research, the researcher is involved at all stages of the research. So he's still the person that is going to propose the pattern of the findings. For example, somebody who said, I want to see patterns of barriers to, let's say, barriers to antenatal antenatal physiotherapy, barriers to antenatal physiotherapy. Immediately he says he's talking about barriers to what do you call it, antenatal physiotherapy. He has something in his mind. He definitely has the way he wants to look at the pattern. So he wants to look at the barriers. He definitely has something in mind. So the way he's going to develop the questions and whatever he's going to state is based on how he perceives the situation and how he thinks the situation should be. So in a way, even though he has not developed the themes of the study, the themes of the study, but he has a pattern. He has a feeling that this is the nature of the questions that are very likely. So he's the one. It involves predicting a pattern of outcomes. In terms, the questions he's going to ask, they are the one to produce the outcome. So based on the theory he proposes, he's going to ask specific questions, so that the questions are the ones to explain what he found in the field. So again, explanation building. This one involves attempting to build an explanation while collecting and analyzing the data, rather than testing a predicted explanation as in pattern matching. So in pattern matching is basically about the questions and how the question is going to bring out the information you are looking for. The explanation building is about now you've gathered the information and you now need to interpret your findings. So then we have the inductive theoretical approach. This one seeks to build up theory which is adequately grounded in a number of relevant cases. It's referred to as interpretive and grounded theory. So in this inductive theoretical approach, here we do not have a background let's say, theory that we actually develop. We are the ones that are trying to. You have a number of, let's say, we say it seeks to build a theory. It's the one that is going to build the theory, which is adequately grounded in a number of relevant cases. Why do pregnant women avoid antenatal physiotherapy? Now, immediately you ask this question, you may actually start saying that there is, what you gathered is that based on grounded, a number of adequately grounded number of relevant cases, you've, based on your practice, you actually realize that some women told you that I am afraid of abortion. I'm too fragile to participate in antenatal physiotherapy, and me, I'm too skinny. It is only those that are fat that are supposed to participate in this. These are adequately grounded number of relevant cases. So people have actually said a number of things about it in the past. So now what you wanted to now do is that confirmation of this, so that you can build a theory around it and say that this is truly the reasons. For example, you don't know whether those things are actually relevant as adequately grounded number of relevant cases, that cases have actually indicated A, B, C. Being lean, I'm not fat enough to participate in exercise. Both those that are pregnant and those that are not pregnant have always looked at being body weight as a reason for them to participate in exercise or not. So therefore, you are considering it. Would this be one of the theories that explain why women are running away from, pregnant women are running away from antenatal physiotherapy again, and so many other things? Oh, no. I think I'm afraid of complications. Can this also be one of the reasons? I think I'm scared of abortion. Can this be one of the reasons? This is my first pregnancy. So those who are in their first pregnancy, they are more scared and all that. So these are assumptions. But then, can you develop a theory around this and conclude that those assumptions are actually making sense or not? So the art of interpretation, field text. So when it comes to interpreting undergrounded theory, we look at the field text. What are the information gathered in the field? That's in terms of the transcript. It consists of field notes and documents from the field, the information you gathered, the field notes, what you jotted down during your interviewing or focus group discussion. So those information, those are what we call field text. Research text, notes and interpretation based on the field text. Now, there is no much difference between field text and research text. They are literally the same thing. Working interpretive document. Writer's initial attempt to make sense out of what he has learned. So at the time you were actually doing your probing or interviewing, there are some things that are making sense to you, and you start writing them. That could this mean ABC? We call them writer interpretive document. At the time you are trying to take down your transcript, there are specific jots. They are not exactly the statement of your participant or respondent, but they are perception of what you actually think. Then you have the public text, the final tale of the field. What is the general overview of what you put down? Not this public text is equally not from the respondents. It's your view about the field at the end of the interviewing or focus group discussion. How do we collect data in qualitative research? So the first one is what we call, now, previously, quite a number of people actually have a feeling that when they say qualitative research, one of the things they think is some people actually think that qualitative research only implies interviewing people. And that is not true. There are quite a number of other ways of administering qualitative research, not necessarily interviewing. So one of the approaches of qualitative research to collect data is actually what they call interviewing. So it's a process of collecting data in qualitative research. It is not the sole qualitative research. And this is very important for me to emphasize, because some people actually think that immediately you talk about qualitative research, what it is referring to is actually interviewing people. So, and that is not true. It's one of the processes of collecting data in qualitative. So you can, when they talk about in-depth interviewing, it actually implies raising questions, specific questions, which we call them interview guides. When you come up with those guides, you use those guides to probe about the particular subject that you're trying to conduct a research on. So we call it, and it's usually a one-on-one interviewing of subject. So an individual is interviewed at a time when it comes to in-depth interview. It could be physical, and it could actually be physical. It could be virtual. It could be physical, it could be virtual. All are acceptable. But the main thing I want us to understand is that it is just a process of data collection. And it is the most popular when it comes to qualitative research. One of the most popular way of collecting data is in-depth interviewing. The second one is what we call focus group. A number of times we call it focus group discussion. Why is it known as a discussion? Because it's just like an interaction between the researcher and a group of people about a particular subject matter. So, you pull a group of subjects together, and they sit down usually in a round table and discuss about a subject, about a scenario, about a situation, and the researcher takes information based on what they are expressing. Oftentimes, it's often recommended that you have between 6 and above subjects. You could actually have 5, but usually 6 subjects are seated, or respondents are seated together in the same place for the interview to take place. It could be physical as well, and it could equally be virtual. You can actually have your focus group discussion even on Zoom, just like we're talking now, and you pull people together, and each one of them express their perspective or opinion about the subject being discussed. Then we have participant observation. In observation here, you have a situation where, let's say it's a geographical area that you wanted to go and take information about that area. And I sometimes give example with, you have a situation of cholera outbreak in a particular location. And now you wanted to write about it, but then you do not intend to actually talk to anybody. You feel that the environment could be the culprit, causing the outbreak of the cholera. In this situation, you may not necessarily interview anybody. You can go from section to another section of that particular setting, observing the environment, talking about the gutters around, the cleanliness of the environment, and documenting this observation and pulling them together is equally a qualitative form of data collection. And you can actually write a paper based on your observation. With evidence, sometimes you can take photographs and attach it to your research, and definitely it can be accepted. You can equally talk about a situation in a given hospital where they say there is negligence of, let's say, taking care of, let's say, pregnant women. When they come to the hospital, they hardly get the needed attention. And you wanted to make observation about whether what people claim about that hospital is actually true. Or let's say people take some water in a hospital, and they tell you the tap in that place could be responsible for the outbreak of a particular disease inside the hospital, and therefore you wanted to go and take notes of what actually is happening in that area, and at the end of the day you came up with something. So that's another way of using observation to be able to come up with what do you call it, your observation and interpret situation. So when it comes to ethnographic studies, it's actually a branch of anthropology that scientifically describes specific like human cultures and the society. You basically in ethnographic study, you want to look at a group of people and how do they perceive something based on their culture, both based their social interpretation of it. How do they perceive it in their setting? So you are more concerned about a perspective of a group of people in trying to express what is going on about a subject matter. So this is one. Can you answer this call? Tell him I'm busy. So this is one of the things I want you to that's if he calls again, you just pick it. Mhm. Okay, then projective techniques. Here it requires that where the researcher actually projects the existence of something, but oftentimes in projective techniques, they prefer the use of documents where you have available documents. It's not like retrospective studies, so that people don't confuse what I mean by using documents. You can have writings, but these are not, and it is not equally a systematic review. Let's say, for example, let's say we want to know the content of a curriculum and the adequacy of the curriculum in giving the type of knowledge we expect it to give. For example, what is the quality and the content of the curriculum of neurological physiotherapy in undergraduate physiotherapy in Nigeria? So we want to see, and in comparison with what is required in the field, in practice, what do we expect, right? In the curriculum, does the curriculum reflect what is expected of individuals when they actually start practicing? So in this case, you have a projection of this is the technique. You go through the projective technique to now do analysis of that and express the situation the way it is. So analysis. Now we're going to analysis of qualitative data. So and I think this is going to be the final aspect of it. So in the first place, we probably I may go back.
Excuse sir.
I may go
Sorry,
back.
sir.
Yes.
I don't know if it's just me. The slides is still on the first one, so we don't know what's going on. Yes, sir.
The slide.
Yes.
Which first one?
I don't know. On my device, I can only see the very first slide for the past an hour and a half.
Okay, let me work on it. I thought you are seeing my slide.
We are not. Thank you, sir.
Yeah, please.
This
You would have you would have said that now.
We didn't want to interrupt.
Okay, all right. Please, let me ask somebody to help me check. Me, you know your organos.
We even sent text charts that the slides is not moving.
Okay, me, I'm not. You know, the thing is, it refused to come on this page.
Okay, this is another Jibril.
Oh, so Jibril and Jibril, oh, thank you. So let me see if I could. Let me stop the share and try again. Go. Can I stop the share and quickly try again?
Yes, yes. Awesome.
Let me try that. So I came again. Use an entire screen.
Visual something.
Is it appearing now? Can we view it now?
Yes,
Yeah,
it
it
is.
is.
I actually
Yeah.
sent a message to Yakub since, and he said he was going to call you, but I don't know whether he
You
could.
didn't call me actually. So
Okay.
let me move it and see whether you can see it.
We can see now.
Is it moving now?
Yes,
Yeah,
it's
it's moving now. It's moving.
Okay.
It's moving.
Okay. Okay, I think we are here now. We've talked about in-depth interview, focus group, participant observation, and all that, right? So let me go into analysis, qualitative data and approach. Now, in qualitative research, one of the things that we need to understand is that when the researcher is conducting the research, the main thing he does is to write down the expressions of the participant. But in writing down the expression of the research of the participant is often very difficult. And that is why it is advised that you should record whatever the whatever the respondent is actually saying. Currently, there are a number of softwares, like they call it Atlas Q, Atlas K, or Atlas Q. It helps you in categorizing the expressions of the respondent. So after recording every bit of what the researcher of the respondent, what the respondent says, you are expected to sit down and write those things. Transcription means that you are what the what do you call it? What the respondent says in his own voice or in his own words. You sit down and write them out. My view about pregnancy antenatal physiotherapy is that I think it is very okay, but I am scared of it because this is my first pregnancy. This is one of the response probably that you get from let's say a respondent. So this is what they express. So you've actually recorded this, the voice of the respondent. Now you are expected to now write down that expression. So the writing down of the expression of the respondent is what we call transcription. They call it transcription, which means you are transcribing it from what? From what do you call it? From voice to words. You are transcribing it from voice to word. So you are making it, and it is expected that you should actually write this thing often verbatim. You are not expected to significantly, and I'm using the word significantly not in perspective of statistics now, in perspective in a subjective way, that you are expected to not to significantly modify the statement of the what do you call it, the respondent. For example, the expression of writing is that we write in English in trying to convey our information. But here you have a situation where somebody used pidgin English to express herself or himself. Now, I dey fear this kind of exercise. Oh, hey, what go happen if I can't lose my pregnancy? Now, if you are transcribing and you write exactly what the the respondent says with the correct English, you are not distorting the statement of the respondent. You are not distorting the statement. if you correct the English, you are not distorting the statement of the respondent. However, there could be circumstances where you want to express it the way it is. I dey fear to participate for exercise. Oh, you go, hey, I will allow myself to come lose my pregnancy. There could be, if you want to express it in that way, but then in your interpretation, you decided to you make a better interpretation of that, you are equally not doing anything wrong. But then a situation where a respondent is saying something, and because of the bias of the researcher, he decided to interpret it in a way that favors the finding of the study. This is what should be avoided. This must be avoided. So and in most cases where you have a good, good expression of English, you are expected to write what the respondent says verbatim. So this is one of the things. Then there are situations that we have common statements in that are expressive statements. They are basically like exclamation. For example, oh, and so on. You can add those expressions, those exclamations to the sentence. You are not necessarily expected to remove them. You put them the way they are. Now, in analysis, they usually say you have to start with, you categorize the information. What do we mean by categorization? In categorization, I wish I have one example that I can give directly, but then let's look at this. I was talking since about antenatal physiotherapy, and here one of the things that we are trying to say is, can you tell me one of the reasons why you feel you are interested in antenatal physiotherapy? I think it's going to make my body strong. Generally exercise used to make somebody very active. I want to be active. I've been sleeping too much, and I was thinking that if I do exercise, it will reduce my sleep. I'm becoming too big, and I'm thinking that if I do exercise, I'm going to reduce my weight. They say that if people do exercise, it can help you reduce your weight. I don't like this fatness. I don't like it. Now, when you look at these, I make different statements. But now, in this statement, we can look at the perspective of each and every expression and say that these statements, they look alike. Categorize them as being a particular statement that look alike. Then you go to another place, you categorize those statements that look alike. Then you can decide to give them a general name. You try to give them a general name that, let's say, understanding of exercise. You understand? Participation in exercise. Fear of exercise. So you see, you are categorizing. So based on the categorization, you can now unitize the data. Unitization is that even though you've categorized them as belonging to the same place, but they are not the same expressions. They are not directly saying the same thing. So you can now unitize and say that I've done my categorization, but I think A, B, C, D of a statement, they actually can be united to mean this particular data. Then A, B, C, D of a statement can also be in this unitization. So you categorize, then unitize. I don't know whether I'm being clear. Then recognizing relationship and developing the categories you are using to facilitate your interpretation. So for a person that wanted to do analysis of qualitative study, you have to be very, very careful and read between the lines and understand it very, very well. So you have to have a sense of being very careful. You recognize how do these statements relate with this one? How do the statement help you in creating the categories? So that when you are categorizing, you are not putting things that are not making sense, that are not related. You are not putting them to be in the same category. So at the end of the day, based on this, you'll be able to make a better judgment of which category, which unitization are you going to make. So you have to be very, very careful in trying to understand this. So you need to read your transcript over and over and over again. In fact, you may finish categorization and later you realize that some of the things you put under a particular category are best fitted for a different category. So you have to continue to do that until you are finally satisfied with your categorization. So actually, the issue where I say testing hypothesis is actually testing your objectives, not you don't have hypothesis in a qualitative study. So developing and testing your objectives to reach a conclusion. So one of the things that I actually want to say in this developing and testing your objectives is that you see there is one thing. A number of times when students are conducting research, they write, this is the objective of the study. But when they are trying to write conclusion of their study, they do not go back to the objectives. They do not go back to the objectives. They just create conclusion. Everybody just says conclusion, this. So how do you think the findings you have actually addressed the objectives you have at the beginning of your study? So there must be a link between the conclusion of the study to tell us whether this conclusion stands for the objective you are talking about or not. So if you are not unable to relate your objectives with the conclusion, then what conclusion are you giving us? If the conclusion you have does not favor your objectives, there is nothing wrong with that. You are being very sincere that even though this is the conclusion of our findings, it does not favor our objective. There is nothing wrong with that. But make sure you are able to relate your conclusion with your objective. Very, very important, always. Whether, in fact, this applies to both quantitative and qualitative studies. So what is the interactive nature of the qualitative process? So number one, data collection, data analysis, and the development and verification of relationship and conclusion are all interrelated and interactive set of processes. So your data collection, your data analysis, right? And the development and verification of relationship in making your categorization and the conclusion you are going to arrive at. All of this. That is why, and in the data collection, what are you trying to address in your data collection? You are trying to address the objectives you set for yourself. Now, when you are now making analysis, don't forget the fact that you have a particular objective you want to accomplish. When developing your group, don't forget about your what? Your objective. When making conclusion, remember, does it align with your objectives? So all these are interrelated and interactive set of processes. So it allows researchers to recognize important themes, patterns, and relationships as you collect the data. So when you actually follow the first statement, which is talking about data collection, data analysis, and whatever, it actually allows you to be able to the researcher to recognize important themes. So how do we recognize themes? How do we formulate themes? Themes are actually formulated from your categorization. So what do we mean by that? You've actually pulled this information together and say that they are interrelated. What is the compound name that you can give the expressions that you have? What do you think all of them are saying that look alike? All of them are saying that exercise is a valid, antenatal physiotherapy seems to be very important and valid in antenatal whatever. Oh, fear is the major limitation. So we can also say fear of the unknown. Let's say, for example, let's say fear of complication as a team, right? And so many other ways of, based on the expression they give, and you decided Somebody may, like I said earlier, somebody may look at it and give it a different title, a different name. It does not invalidate the name you have given it. That is your own feeling that I think these things should be named like this. That is your own thing. It does not invalidate your own because somebody look at it in a different way. I believe I want to believe that we are understanding this one. So allows researcher to recognize important things. So when you do a proper categorization of it, so you'll be able to identify the things you want to attach and the patterns of expression and the interrelationship between one expression and the other. All these can be made clear when you do make sure that from the data collection to the development of and verification of relationship and conclusion, they are all made. You'll be able to do that. It allows you to categorize existing data to see whether themes and patterns and relationships exist in the data already collected. So when you do your categorization properly and you are following the pattern of saying that you have data, you have analysis, you have development and verification of relationship, now you'll be able to say that, no, this does not belong here. It should fall under this category. It should be here. It should be here. Just like I said earlier. Allows you to adjust your future data collection approach to see whether they exist in other cases. All this is possible through interactive nature of qualitative process. So what are the tools for helping the analytical process? Summaries. The summary should contain the key points that emerge from undertaking the specific activities. So in every case after making your categorization, try to develop summaries of that category. Each category must have a specific summary. So if you now do a specific summary, in fact, a number of times when you do your specific summaries, and the summaries can even guide you towards coming up with the theme. So allows you to make a record of the ideas which occur to you about any aspect of your research as you think of them. Do not always continue to do qualitative research without monitoring what is going on. As it is going on, you keep putting down information. You keep putting down information. When you keep putting down those information that you are putting down can actually, they are self-memos, and they are actually going to help you in your interpretation. Then you should have your own research diary, starting from the collection of the data to the end of the data, particularly in the field notes. You should be able to put all these down. Thank you very much. So thank you very much. Questions? What are your questions? Oh, am I audible?
Yes, sir. Yes, sir, you are.
So I'm waiting for questions. We have come to the end of the presentation. Any question? Professor Jibril, are you still with us? Do we have questions or we don't have, so that we can round off this session? Shetima, it's been a long time. How are you?
That was shine yanzu da nake son mu ga me sunan sa kawai. A shi ne ba wa. Ko zan duba iya shine kadai me wani wannan.
Mr. Nasir, you are disturbing our session.
Da akwai 2023. Shine yanzu da ka gani?
Mr. Nasir, you are disturbing our session. Can you mute yourself? Am I audible? These people are not serious now. Shetima, how are you? It's been a long time.
Yes, sir. How is family? How is work, sir?
Fine, thank you.
Yes, sir. I'm grateful, sir.
Where are you based now?
Currently, I'm located to Maiduguri, sir.
Okay, all right, all right.
Yes,
So
sir.
you are back home.
Yes, sir.
All right.
Yes, sir.
So in the absence of questions, I think I'm going to go. I have so many things to do. If you guys don't have questions for me, it seems like some people take this as a formality. Are you online, Yakubu? Are you online, Yakubu? All right. So I've rounded up my session. I don't know whether there are questions and people are not responding. So I want to turn off the. All right. Okay. Okay, you will send it to me, huh? All right, thank you. Alhaji Awaisu, how are you? Okay, I'm gonna round off here, and
Good evening, sir.
can all of you, can you on your wherever, can you open your videos to just have a quick snap picture for everyone? Can we take a quick picture of everyone?
Good evening, sir.
Alaikum salam. How are you doing?
I'm fine, sir. Thank you for the presentation, sir.
It's a pleasure. All right. I think we can call it a day. Thank you very much. Oh, you have a question?
Yes, sir.
You have a question? Okay, can we go on?
Yes, sir. Yes, sir. Sir, my question is this. I need more clarification on the difference between discussion and
difference between
focus group interview.
An in-depth interview?
Yes, sir.
Okay. When we talk about in-depth interview, it's usually often one-on-one questioning between the researcher and the respondent. So usually it's just one person at a time. One person at a time is being interrogated on the subject. That is what is done in in-depth interview. But when it comes to focus group, you usually pull a group of people. Like I said, usually from 6 and above. Often it is not expected to be overcrowded. So usually they recommend 9 to 12 as maximum. And all of them are pulled together. It could actually mean that you sit with them in the same place and you discuss specific topic with them regarding your research. Then you could actually do it virtually, but in virtual sense too, all of them must be listening to what the other person is saying, just like what the interaction we are having here. It could actually be in form of so we can do this kind of discussion in terms of you are all virtually listening to me, but then you can make contribution
to the airport, that's very good. So maybe when you are in,
so
approaching the gate,
in terms of questions, sometimes the type of question you ask or the objective of the study defines whether you are going for a focus group or you are going for an in-depth interview. So questions also can determine the choice of the result, whether he goes for in-depth interview or he goes for focus group.
Okay.
So, but the main difference is the number of people to be interacted with.
Okay.
All right.
Hello, sir.
Any other question?
Hello, sir.
Yes.
Just in relation to the answer you just gave.
Yes.
From the little experience I have, if you're going to population also matters. I don't know if you can shed more light.
Like I said, for example, like I said the objective of the particular research.
But what if the population are not going to cooperate?
Cooperation. You see, the cooperation is another aspect, but usually the cooperation of the subject is not supposed to be a major determinant of choice. It is not a methodological factor, but a feasibility factors. Now, at the beginning of your research, you need to have a feasibility. You know how feasible is it for you to adopt A or B of a research approach. You understand? So if at the beginning of your research, at the point of feasibility, you actually look at it that I'm going to encounter ABC of a problem. So you can choose the one that is more appropriate for the research. I don't know whether my
I get it. Yes, but thank you so much.
I think we can close the session, right?
But sorry, before you close,
all right.
The issue of sample size and qualitative study.
You are not very audible, Dr. Professor.
Okay,
Jibril.
I think. Okay, I said that the issue of sample size in qualitative studies is always tricky for people. Sometimes they mention data saturation. I think we can have a way of normal quantitative research. So if you can give a brief overview.
Your audio, please.
That closure, whatever, and shift it.
Yes, some people are talking on the ground.
People are not muted.
Yes.
You are like the sample size, right?
Yes, it's always an issue. As in, what I mean, how do you determine?
It's like they acknowledge.
Okay, how do you determine data saturation?
Data saturation, yes.
Yes. Now, you see, in the first place, you know, we talked about, and I'm very glad somebody talked about the issue of generalizability the other time. You see, in qualitative research,
all of them, they must.
Pardon?
Shetima,
Shetima, can you mute yourself?
Okay, sir.
Mute yourself, please.
Okay. Thank you, sir.
So what we are saying is that when it comes to sample size, truly is a challenge. But one thing that we need to have at the back of our mind is that in recruitment of subject first, that's the beginning. Remember that there is only one technique of recruitment of subject in qualitative research. And that recruitment technique is only purposive. Literally, all subjects that will participate in qualitative research, we recruit them through purposive sampling. That is one goal. Now, why do we use purposive sampling? We actually use purposive sampling because we have a target. The answer, what we want to answer, it's only those people that can answer that question that will be involved, that will be included in the study. So there is a criteria for recruitment is that people that can attempt our questions are the ones we are recruiting. So that's why we use purposive sampling, case 1. Case 2, because they now have equal, let's say something that looks like they have the same experience in terms of, the same quality of being able to answer our question. At the end of the day, it is easier for literally all of them to be saying the same thing at a particular point, such that I have asked about, let's say I have total of 15 subjects, about 20 subjects that I intended to recruit. But then when I reached the 11th person, I realized the answer he's giving me has been given by somebody in the previous questions I asked. Not necessarily the last person. One of the participants has given me this same answer previously. Right? Then again, as I move forward to the, let's say to the 15th, let's say 13th person, he was also giving me the same answer that was given to me by someone. One of the participants has actually given this answer. And this has remained consistent for the next 3 to maximum of 4 participants. They are actually not bringing something new to the table. So that indicates that I've reached data saturation.
There's one banker in Yola.
I don't know whether it is clear, Professor.
Yes, sir. Thank you.
I was trying to explain when they see like
Shetima, please, Shetima.
I said yes. So you couldn't, even like I say no. That's how it is.
Shetima doesn't know how to mute himself.
So that you 1 week.
No, I mean no problem.
Any other question?
No, sir. It's okay. Thank you, sir.
Brother.
So I think we can call the say bye to everyone. Thank you very much for participating, and have a blessed day ahead. Bye bye.
You know, I hope this is my 47. 3,000 when I get behind that song it was later now, yes, now I was in the army, yes. But even yeah, but it's not a big deal. But I was even working as a dispenser in church before joining. Yes. So even by then, I think 1994, my salary was 3,000. So before when I joined, started going to school. This was not because I still did dental another separate group. So before I start this one fresh. Yes. So, so that one is that. So if I see the problem of this 26, 10 to 27 years, there's no changes in the army. That is why one of my patients changes. So yes.
This guy you see, bro.
Yes.
It's from Kaduna, and junior brother. We never even knew until 2 days ago. Yeah, we were roommates.
Okay.
When he was in level 1, he applied for the same course. It's level 2, he applied. I think it was the time they qualified him to go and
yes.
But if he met you earlier and was telling you about this, maybe he would just believe that all those vibes, he would have even entered completely.
You see?
Although some of them, maybe it's not really, unless it's not really so for all.
Yes, no. The good thing you say something about maybe his one is NDA.
NDA, yeah.
You understand? So it's good if you started at that NDA.
Okay.
Secondly, as a graduate again, that's DSSC. You understand? Yes, direct a short service commission. So if you are graduate, that range age of 25 to 35 as a graduate. So when you commission as a lieutenant, that one is a good starting point.
Even direct short
service. Yes, direct lieutenant. Then yes. Then the NDA, I think 18 to 22. Yes. For NDA, that is start 100 level. You will spend like 5 years. When yes, the degree for as a second Then after 6 months, then they will give one to them. That one is also a good starting something. Yes, you understand. So the commission, there are different types of commission.
Yeah.
So but that one you have to go for 5 years in ND, and your age limit you should be 18 to 22.
That one is within the people that can still go
Yes,
to university.
yes. Then the graduate one age to 25 to 35 years. So all those ones is a good something if you are commission. Yet I mean that sweet, but you know your rank you keep on coming at the appropriate time, and you have something is a officer you keep on going as an officer compared to the other one. The one that we join, not that one. The one is through default.
Yeah.
You understand? Through other one. You pass out at default area. So that one you start as a private, as corporal. You understand?
Yeah.
So that one the worst things
The growth is quite slow there.
yes. So the issue, even they say promotion is 5 years. You may not even see it in the you understand? So and you are when you look at them, they are just things with you just more or less like slave spam. You understand?
Yeah.
More or less compared to the income, the density of the world there is high compared to the one soldier. So it's just
That's why many forces, not just civil soldiers at home, but our police, our federal police.
yes now, but even compared to that, the soldier is even better than all this one. That one is even worse. Soldier is even better.
That's why if you see them competing, my village, you see many of them, they collaborate with when you hear they happen, you see them, these rifles that these guys are using,
yes,
they don't own them. And these rifles were never seized. And this same rifle you see them holding, the following morning you see some police people having the same rifle.
Yes.
So how they get? So they'll tell you that they can't hand over
Yes,
so and so,
but
but they are doing
somebody
such.
he left his family, everything, he's sleeping outside, being also the risk taking, then you did not even give him his salary. So what do you expect him to
My dad told me a story about them. That there was one certain time that some people just gang.
Don't like
Just
that.
gang up and they were terrorizing the kids. So they continue for a long time. They know them. But with the pastor,
they can't.
So what they did was call those guys, call them, like do a kind of is it treaty they call it or something of that nature. Call them and tell them and see, we'll be paying you guys this one, so I'm money for you guys to secure.
Yes.
Since that day, everything
At
is
least
stopped.
yes.
Now they even know the people that are not from there.
Oh, yes.
So if
They
those
will
ones
know.
are coming, they'll be the ones to even come
To
over
stop,
there, tell
yes.
them that these
So
people
that's
is
how
our
it
people.
is. If that
Now
is
we have a contact with this guy, so you can't come in. That's how
it's,
everything
it's a good plan. So that one exactly is affecting the army. And when you even started, even though you are professor, army doesn't add anything to all these studies. You understand? It's good the first one that is army sponsor, but the second one is not army. Even the army one, the one that army sponsor, it doesn't add anything.
Once
You
you're in the
understand?
army.
Yes. It doesn't.
That means they do like UBA.
So
They actually call it like UBA.
you see,
a colleague of mine that came from there told us about the way
UBA. So it's the same thing. So that was exactly so somebody like us, we are even somehow late. Supposed to have left him before clocking 20 years. But due to the nature, when I was doing internship at AKTH, I wanted to finish and put paper. Along the line, they just forced me to Northeast. Even without, yes, that was exactly it. So I have to go and spend like 2.5 years in Northeast. You understand? So coming back, in fact, as soon as I came back from the Northeast, that's
okay.
Yes. So I came, I finished the internship. So those are the issues. I mean,
and someone somewhere is aware. Someone somewhere knows that.
Yes, even the like I said, I studied in this Bayero University. So I was disturbed in that I'm studying. They disturbed me. In fact, even I can remember I was in 500 and I was took up to this Kaduna. There's one operation. I am Kapatu in Briningwari.
I heard of
yeah, so I think we are second set of that going to that. I was in 500 level. This one that this Zoom that is going on, this very the same like this lecture because the Zoom lecture is on. Yeah, just called me. This the same lecture. I think I called him that time CCC, but they have started even test address. So that's how I reported to him that see why by the grace of God. Just got that just got it. So I made one general act exam. He did not even ask me which exam.
Just let you
It's just why medical like that? Medical are wicked. Somebody is in school, send him to this because supposed to be selected. So the commanding officer he knew I'm in school and he was even telling me by 2 months I will return him. So that general just
okay. I'll quickly open it. Yeah.
Thinking
2.5 pages.
Yes. Sorry.
I wasn't trying to log on. It's not open. That's why I needed to. Let me use. Sorry, discussion. Let me just. Let's just reschedule first.
Okay, Thursday.
Tuesday. I'll first of all report to clear some maybe 2 hours of the time.
No,
I'll give you a call.
Oh yes. So no problem. No, maybe you can even give me a call. If you are here, everything is okay. Anyone,
as soon as I get I'll do my work this tomorrow morning. I'll call people, so everybody will start
yes. So as you said, I don't know. Later, maybe you get the phone from
the only thing that was the sign up.
Okay. So no problem. Okay.
But you still dey announce you. Where will they have?
And they say they will. They will call me at their own time, but it can be any moment. Yes. Okay, Tom. Thank you very much. I'm going to pass. Thank you. Yeah. Thank you very much. Yeah, thank you. Yeah. Hey, my friend. Thank you. Yeah. Okay.
I'm using it to restrict me, but look at but this one, I don't put this one can be fixed. That will work. I want this. Yes. Yeah. Yeah. Everything. Yeah. So, yeah. Was. There was. I think you should be able to do something. Maybe let's not the leg up front. You know, yeah, well, yeah, I bet you lift that up. So, if I say, it's on. Don't let that. That's good. Hey, yeah, so don't. Hey, yeah, don't. Hey, yeah. Okay, this is great. Yeah. Good. Setting up. Yeah, if you are waiting, I need to do that. I can't get it. No, hello. Okay. I got it. Land. When you be. Yeah. No one. Mama, the BSN is right. And that's one of that. Ah, wow. What's the say your phone? My giant. Yo láti ní ìṣíwájú ní màá wá sí. Ẹ máa fà bí ìṣáájú. Ìṣókè. Ẹ máa bó kẹsẹ̀ yìí. Ẹgbẹ́ ní ìṣíwájú. Wá fún ọ̀sán ọ̀hún. Yeah. Ẹ̀fọ̀gbọ́n sún ilé ìṣíwájú ọ̀gá. Ìṣíwájú. Ẹ má jà ẹ̀. Ìgbé ṣubú. Ìgbé ṣubú láìláì. Ìṣíwájú. Ẹ̀yin ló ti náà lọ ẹgbẹ́ tọ́ ni ẹ̀fọ́ gbé ra ẹ̀ sókè ẹ̀fọ́ gbé ra ẹ̀ sókè ẹ̀fọ́ ti ra ẹ̀ sókè ẹ̀fọ́ ẹgbẹ́. That's my right leg not touching the ground. It's on my root here. That's right. So when you lift her waist and she looks to carry,
Hello.
Take out 2 weeks. 3 weeks. Take out that. Don't talk. Because she has already stressed. Whereas we got to do it with all our efforts. So we produce adrenaline. That's where it comes out. So immediately after that, but so next time when we are doing this way, now she wants to walk. So next time I want to, the meaning of the shape. So then about one to the back. So stretch my root half.
We don't have the teacher. Please, congratulations. Congratulations.
I want to.
I don't get it.
I tried to airport. About manager. Ohun do caralho, Google Calculator on there. Everyone does. Later, you to what be I want to try reading.
Oh, that's why.
Think about the money. And about much about I think that
Dọ́kítà mo dúpẹ́ lọ́wọ́ Ọlọ́run dúpẹ́ lọ́wọ́ bí ẹ ṣe wá ń tí ẹ ṣe o.
I was to say, I was to say,
Ẹ ṣe o.
they must be there. Once today about you is our own. They are the same things you are not doing. As you saw with you.
Mo tẹ̀ tí ń fa at least wọ́n ti ń fi ẹ̀gbọ́ sọ wọ́n ti no at least wọ́n ti ń ṣáìsì. Wọ́n ní ṣe ẹ ṣe àpolówó ọdún ojú ọmọ àárọ̀ ọdún lórúkọ Jésù àṣìkà happy new year. Kọ́pà ní tí wọ́n kọ́pà ní tí wọ́n tẹ̀lé. Ká má ti mọ gbogbo. Ẹ̀gbọ́n yẹn. Ọjọ́ mi. Báwo ni ara àwọn akẹ́kọ̀ọ́ ṣọ́ ẹ ti fi wọn dé? Anxiety láti dìde àbí láti. Okay.
One express emotion.
Okay.
We'll get you fighters. So I need to rest. Go express.
Kí ló ń ṣẹlẹ̀? Thank God,
Cool, are you there? Are we there?
Ìjẹ́ kó pọ̀ àwọn kan tí wọ́n fi sí ibi yẹn. So àwọn ọ̀dẹ̀ tí yọ ọ́ lọ́dọ̀ di 8 kan tó yọ. Ọgbà tó ń bá yọ. No, ó lè wà ó lè kú jẹ kí ṣe ó ti ẹgbẹ́ kí ṣe ń YouTube àní tó akọ́sítọ́mù bí.
Wọ́n lu bí.
Àwọn lu. Àwọn ló wà síbí àná.
Olùbílẹ̀
àti ìlú láti fi sí. Wọ́n lè tí kọ́ wọn ẹ̀ṣin. Ìdí ìgbà tó bá rí bí ẹ̀ wọ́n lè bẹ̀ ó ti lè kó fẹ́ máa sọ̀rọ̀ ní òbíbẹ̀.
Ìyẹn lè sọ ìdẹ́kọ̀ sọ. Àṣọ̀rọ̀
àwọn ẹ̀dá
testimony ló máa jọ sí. Testify.
Ànọ́bà ó lè stand ní 10 minutes. Ó lè stand ní ẹni.
Testimony no matter
what you increase because of that emotion you always share with your friend in these areas. Why express a phone call?
No, my unit. I'm 43. So young. Ọmọ gan-an kéré ojú ọkọ yẹn gan-an wọ́n lè kó ìrọ́pọ̀ ojú ẹ̀ 43. Kéré ọmọ mo máa ń.
Good evening. Can we see the slides?
Let's have one house. Please let's mute our microphones and have one house. Good evening, everybody. We are going to be taking the last presentation today by one of our esteemed facilitator with the name Professor Bashir Bello. Professor Bashir Bello is a professor of orthopedic physiotherapy from the Bayero University, Kano. So, Prof, sir, you have the floor.
Thank you very much, Dr. Akubu. Good evening, colleagues. Let me show myself just to fulfill all righteousness. Those who were well acquainted with each other, you will still recognize the face. And of course, for my other colleagues, this is the first time we're meeting ourselves virtually. I want to welcome everybody to the workshop. For this last aspect of today, we'll be taking the issues surrounding professionalism in physiotherapy in terms of how do we enhance our professional roles and responsibilities. So just to ensure we have clarity, of course, if you could hear me properly, you can just agree. I put off my camera and then you ask me to continue. Am I very audible?
Yes, sir.
Yes, sir, you are audible.
Hello, colleagues.
Yes, sir. Yes, sir. Yes, sir.
Okay, so we can go ahead.
Yes, sir.
Without the camera so that it can enhance the presentation. So do you permit me to put off my camera?
It's okay, sir. It's okay, sir.
Thank you.
Please, every other person, please mute your.
So for this presentation, our main objective today is to see what is the definition of professionalism in the context of physiotherapy, and we go to explore the key attributes of a professional physiotherapist. I mean, what are the key attributes? What should a professional physiotherapy has as qualities or attributes that you must possess to function properly as a physiotherapist? And of course, we also want to understand the ethical and legal responsibilities that are bound to us as physiotherapists. And then, of course, we're going to discuss the importance of interprofessional collaboration, while we try to highlight, lastly, the strategies that we could use to maintain and improve professionalism. So as a way of introduction, we say professionalism is the consistent demonstration of ethical practices, specialized knowledge, accountability, and respect in fulfilling a professional role. So it means if you don't have these qualities of demonstrating your work based on ethical practices, you don't have specialized knowledge. It means for you to be a professional, you must have some specific knowledge that no any other person has. And of course, you should be accountable for whatever you are doing in terms of treating the patient and relating with the patient. And of course, you should have respect for every law or rule that governs the profession. So therefore, in physiotherapy, we said professionalism encompasses the delivery of high quality, evidence-based care while maintaining respect and empathy for our patients. So it means we can never be professionals as physiotherapists if we cannot deliver high quality care. So we must know the high quality care, and then we must know how to deliver the care. Of course, we must know everything about evidence-based care as we maintain respect and empathy for our patients. Now, why do we think professionalism is crucial in physiotherapy? Number one, we want to maintain the trust and credibility of our patients. Please, we want whatever information, whatever interaction we have with our patient is based on trust. And whatever information we're giving out to the patient is based on credible information. So therefore, professionalism in physiotherapy, we want to have that trust and credibility. Number two, when we practice as professional physiotherapists, it will enhance our patient outcomes. It means we should be able to give out knowledgeable, high quality care based on evidence that are available. And of course, because we are professionals, we want to interact in terms of teamwork. There must be collaboration. The physiotherapy must have to work with other physicians, other specialists, nurses, the dietitian, prosthetist, and so on and so forth. So therefore, teamwork and collaboration is one of the crucial roles we want to work with as a physiotherapist. Now let's look at what are the major components of professionalism. The first thing for every professional is that they must be knowledgeable enough to get some competence in whatever they're doing. So for you to be a professional, you must have that specific knowledge, which puts you at an edge beyond every other person. And then you must have that competency. You must be seen to have the confidence, the competence to, deliver such type of, physiotherapy to whoever clients you're looking at. So this means you need to stay updated, advancement in physiotherapy. Another component of professionalism is ethical practice. It means physiotherapists must know their code of conduct. What are the code of conduct or ethics and the legal framework that is bound with physiotherapists? Most of us do not know where do our responsibility or our role start and where does it end. So we begin to jump into other roles that are not ours. So we must be guided by some ethical codes and legal framework. Number three, for you to, to work as a professional, you must show empathy and compassion. Empathy here means you're not sympathizing with the patient, but you're putting yourself in place of the patient. So it means because you can feel the pain of the patient, you are ready to give out the best you can do, because it's like you're trying to treat them. So you will do your best to give the patient whatever you see that is the best for that patient. So in empathy and compassion, we'll try to understand and address the patient's need holistically. We're not looking at just the pain in the foot or the knee, but we're looking at how the pain is going to affect all ramifications of the patient's life in terms of economic, finances, quality of life, and so on and so forth. So it's not just about treating the pain, it's about showing empathy and compassion. Number 4 component is there must be accountability. Accountability means you want to take responsibility of whatever actions and decisions you make. Recently, I was interacting with an orthopedic surgeon who did, what they call a total hip replacement. Now, this replacement failed, but the surgeon was not ready to take the responsibility that it was a faulty implant that was used, or the implant was not screwed in firmly, or something that he keeps saying, no, the patient is fine, he's just complaining. Because 1 year post-op, the patient can still patch the leg. It means there's no problem. He was looking at only a problem from an aspect of infection. No, there was no infection, but there was a gap in the implant. So this means you should be able to take the responsibility as a professional that, oh, you think there's a problem and you need to revisit the surgery. So these are issues that relate to accountability. In physiotherapy, for instance, you expose the patient to infrared and it led to burns. You have to take the responsibility. You took a decision, then you have to take responsibility of that action or decision. So that makes you a professional. And of course, the last component in professionalism is about adaptability. You should be able to know how do you navigate the challenges and respond effectively to challenge. For instance, when the COVID-19 came in and we needed to have to also go to the clinic. Now, how do you adapt to those challenges? Even if you don't have the PPEs, or if you have the PPEs and all that, the new wave of disease in town, how do you do? Do you run away from the disease as a professional? No, you have to navigate the challenge and see how you go about it. So that's some component in professionalism. Of course, I know most of us are tired. We have been here since morning. So I'm just going to rush this presentation as quick as possible. So let's look at what are these impacts professionalism can have in our careers. I said, number 1, if you demonstrate professionalism in your career, it's going to improve your career satisfaction, that is job satisfaction. Because it's not about the amount of money you're being paid, but how much satisfaction do you get in demonstrating your role as physiotherapist, and of course, in your professional growth. So this is what you can get from professionalism. You know, when you demonstrate professionalism in your role as physiotherapist, you will find out you easily get through your professional growth family. Professionalism, it positively influences our workplace culture, because when you demonstrate professionalism, you know, you don't wear just a pair of slippers to office. Hello, can you hear me? Can I continue?
I tried to so happy.
You see my slide? Continue.
Yes, bro. Go ahead.
Of the impact, yes, of professionalism in our careers, of advancing the physiotherapy profession. When you in Nigeria 20 years ago, but now be as I don't know where it's going up from. I don't know, is it touching it from my side or from the other side? I don't know what's happening, but I hope you can hear me now. Quite worrisome. Oh, sorry. I said there is some attributes of a professional physiotherapist. Number one attribute is your communication and interpersonal skills. As a professional, you must have effective communication system, because how you communicate with one another is key to building trust, understanding, and rapport between you as a physiotherapist with the patient or your colleagues or other healthcare professionals that you work together. So the way you communicate must be seen in a professional way. And I said the element of a good communication is what you must have what they call active listening. It means you should not rush to only see things from your own angle. You must try to understand the patient's needs, their concerns, and preferences without interrupting. So you allow the person speaking to finish whatever they want you to understand. And of course, we should try using verbal and non-verbal cues to show attentiveness. It's going to be very rude of you when the patient is speaking with you and then you're making a phone call. That seems to be like unprofessional. And of course, when the patient is speaking to you, you are there, but maybe writing something, you are not listening. The patient feels as if you are not listening. So these are things we must learn how to do. Because we should also give clear and concise communication. What it means is, whatever information we want your patient to understand, you should give it in a clear and simple language. For instance, a patient went through a full blood count result, and you want to tell them what is happening. You don't say, there's a problem, or this patient. No, madam, your red blood cell count shows it is reduced. The normal is from this level to that level. Yours is showing this, so we need to improve on it. Or it shows there is this, there is that. So we should give it in a clear terms that is going to influence our clinical findings or our treatment plan, or whatever education you want to do should be in the most simplest terms. So this is what professionalism is all about. You don't begin to build the medical jargons in the patient's head. You get them more scary and confused. So therefore, I said we should also try to adapt a specific communication style so that the patient will understand. In this way, as professionals, we should be able to read whatever information another colleague or another profession is sending to you without miscommunicating or misrepresenting the other person's role. Of course, we say we should also be able to communicate using empathy and emotional intelligence. That is, not be carefree on how a patient is feeling. Just yesterday, a patient was sent to me, from the teaching hospital at Zaria, that the patient had a road traffic accident like 2 weeks ago, and there was a fracture of the ankle. The fracture was fixed with a K-wire, So now, unfortunately for the patient developed gangrene, and there's beginning to have necrosis and all that. So the doctor that came to speak with them, of course, the patient were Fulanis. So the doctor felt the patient is coming from a rural area, and therefore he should just tell them this information the way he wants to say it. And all he said is, Mama, we are cutting off your leg tomorrow. You can say, what do you mean? In their language that they are cutting off this whole leg tomorrow. Why? How? What? None of them can answer that they have already had their team meeting, that the team have agreed that that leg is gone. You can imagine if it was you. So the woman is a 2-year-old woman. And the person who sees that leg would believe that she's having diabetes and that's diabetic food. But she was not diabetic. She never had any occlusion of her blood vessels and all that. All brought to the gangrene. We never knew it was just an infection. Infection due to what? Aseptic dressing. No, it was a sepsis of the dressing that caused it. Now the patient's son took away this woman in the middle of the night. I left for Kano. And that's how someone gave them and they found me. In the morning, I asked the orthopedic surgeon to come and review the patient. He came and he said, he's also thinking that we only have 20% survival in this limb. So that he too is scared there may be no salvage for the limb. We sent for a Doppler ultrasound, every EUCR and all that, glycated hemoglobin, everything was normal. Now this patient, and I felt, okay, let's call the plastic surgeon. On this room. Behold, this plastic surgeon said, take the brightness. To cut the story short, that limb was saved. You can imagine they begin to see me like a small God. The way they communicated with them is, Mama, we're taking off this leg. So please, we should show some empathy and emotion. You want to take off somebody's leg, amputation. I mean, you should know the trauma, the emotional, the psychological trauma that will follow that. And they just laughed at it that the team has agreed they are cutting off the leg. So please, let's see, we show some empathy. Try to respond to our patients at the time they are going into some anxiety and depression and fear. We should also look into that. Extra decision making while we try to maintain our integrity. We just keep on making of amputating this woman. So let's see, how do we do that? I said, upholding expert standard is to ensure fair and respectful treatment of all patients. With this, we're enhancing the trust in this profession. It's the same way, I give you a scenario. A patient was brought to me yesterday with a severe chronic back pain. This patient is not hand up. He's walking with hand on the knee. So it's like almost about 80 to 90 degrees bent. Now, when the patient came into me, and I assessed the patient cannot lie on his back, cannot lie on my, cannot lie on. You can imagine what. Now we try to ask the patient to do some, MRI. Let's see how much damage the back is going through and all that. Of course, it's also a 65-year-old man, doesn't smoke and all that. Now, this pain, he said, has been there for years, but now the dysfunction, that curvature, I cannot walk upright now, started just 10 days ago. Now, we needed to know, how do we make a decision for this patient? I asked the patient to do an MRI. You could not stay into the MRI machine. They called me and I said, okay, can we give anesthesia to make sure this patient's safety? You know, now this anesthesia means that you have to do, and then you to maintain your integrity. And I called the orthopedic surgeon and said, what do you feel? He said, everything is okay, but let's discuss with the patient if you will agree with that. Now the patient, the first thing he said is, what are the consequences? That's what we told him. There are no consequences except that after you finish, you'll be drowsy, you'll be sleepy, and sick. He said, fine, that he has not slept for the past 12 days. And this is how anesthesia was done, and MRI was also done. So it means we must have to understand how do we respect the patient. And that's why they said the key aspects of ethical practice are four. Number one is respect of the patient autonomy. It means does this patient have a decision on his own? Assuming that patient yesterday said he doesn't want the MRI, what are we going to do? Are we going to force him? We cannot. It's the standard of care for him, and he said he doesn't want, then we cannot go beyond that. So we have to leave the patient. But now the patient has agreed, and therefore we must follow the patient's right to informed choices. Informed choices means you must tell him the pros and the cons of whatever decision you are making. Do you understand? So that you don't, just try to cajole the patient to do what you want him to do without his will. And if most of you are in any of these, our ethics committee, you will understand these are the kind of things we look into, how to safeguard the patient's rights. The second thing is about confidentiality and privacy. That is, like all this information I'm saying, if I'm going to let you understand who is this patient, why the patient doesn't want me to let you know, it means I'm releasing the confidentiality of the patient. Because I have to safeguard patient information. And that's why I will not mention names. I will not mention the information that will let you recognize the patient, except when we need to discuss this, like in a professional group that we're doing today. With that, I'm still hiding so many information that will not define the patient to you. And I want you to know something about the patient. Confidentiality and adhering to an ethical guideline. Move it out. Move on. In Nigeria, we allow so many things to go under the carpet. So these are not right. Now, another thing is I hope you can hear me. I don't know how it's going off. Maybe it's the host that is trying to ensure everybody is on the same page. I'm talking about the principles in terms of fairness and non-discrimination. That is, you treat everyone irrespective of their, ethical, or their what do you call it? Religion, their language, their, what do you call them? Yes, their financial capacity, because we are used to those kind of things. When somebody who is more placed in the society comes to you, you want to do better treatment than any other person. No, The principle of fairness means you treat everybody equally without discrimination. For instance, in terms of politics, your political inclination. Just imagine the way we're suffering the APC government with the fuel price and everything. And somebody just came, I'm the APC, you want to let me fire him out infrared that will burn all his legs, you know? So, but in our profession, we have to use the principle of ethics, you know? So please, we must understand that as well. Now, we're also looking at the issue relating to accountability. At least when you are wrong in whatever you're doing, you need to acknowledge you're wrong. And then when you are right, you say you are right. So this is accountability. Now, you should be able to report on ethical practices among colleagues when necessary. Now, how do you do that? How do you report on ethical practice? So these are issues we're going to be looking at as we move. Okay. I said, ethical responsibilities form the backbone of professional physiotherapy practice. It ensures patient welfare and uphold public trust in the profession. If we don't have our ethical responsibility, it means we may not be able to even work properly. So, these responsibilities are guided by codes of ethics established by professional organizations like the World Physiotherapy Association, we have our national NSP, National Nigerian Society of Physiotherapy, and the Medical Rehabilitation Therapy Board codes. So all these are where we can find our ethical responsibility. But the core ethical responsibility, like I mentioned earlier, is about respect for autonomy. Of course, the principle of beneficence, and that is, whatever we do, we should act in the patient's best interest to maximize the benefit while we minimize harm. That is an example here. We must use what are the best available evidence to practice whatever we want to do. Of course, we must try as much as possible to avoid interventions that are unnecessary or they are likely going to put the patient into a pacemaker in the heart. And because you want to treat the shoulder and you are trying, you must use shortwave diatemy. How much will shortwave diatemy do in the shoulder than the damage is going to do to the pacemaker due to the synchronization of the frequency? So please, we must try to avoid any harm. Now, another principle is the principle of justice. Like I mentioned earlier, we must ensure fair and equitable treatment for all patients, regardless of race, gender, socioeconomic status, or other factors that we mentioned. And these, we must try to allocate resources appropriately. When we have clinics that are more busy, we should send more physiotherapists to that place, and then we should give them more equipment. Okay? Not to say, oh no, these physiotherapists are for the government house physiotherapists. So therefore, the best hands should be there, and then all the best equipment should be there that are just using for about 10 people. It is in Nigeria, you make a budget that you're going to use for only 500 or 456 senators and whatever, and then you are going to make a budget of about 200 billion people, and the budget of the senators is higher than that of the total population. So this is the misplacement of priority. We must try as much as possible to allocate resources with justice. Therefore, it means we should treat all our patients with equal respect and care. The last one is the confidentiality that we have mentioned, that is protecting the patient information, and then you share it only when it is legally or ethically justified, just like what we have just done. Of course, we must also try to maintain professional integrity. In this term, we must maintain honesty when we are dealing with it. Transparency, let everybody know this is what we are doing. And of course, maintain ethical behavior during interaction with patients or other professional colleagues. Example, you should try as much as possible to avoid any conflict of interest. Conflict of interest, you saw a senator moving into your clinic. Excuse me. You saw it, because it's a senator that came into the clinic, everybody is rushing, treat the patient, rather than allowing whoever has the case file to work with the patient. So those are ways we should try to avoid conflict of interest. And of course, we should accurately represent our qualification and expertise. When a patient comes as a sports physiotherapist, and I know that I don't have the expertise in pediatrics, I will send the patient to somebody who is a specialist in physiotherapy. That way we maintain our professional integrity. There are a lot of ethical dilemmas that can occur in physiotherapy. Number one, we say, for example, a patient requests a treatment you know is ineffective. Ladies and gentlemen, what are we going to do here? Yes, please, you can unmute and speak. Let's see, how do we handle the first ethical dilemma in physiotherapy? A patient came to you and requests you give a treatment that you know it is ineffective. There's no any guideline or for instance, any evidence for you to use that. And that patient said he prefers it. What do we do, professionals? Please, let's unmute and interact on this.
Yes, Prof. I think in this instance,
just mention your name so that I can talk.
Okay, this is Kedone Sonny Emmanuel.
Okay.
Can you hear me, Prof?
I can hear you. Please go ahead.
Okay, so in this instance, knowing that this treatment the patient asked for is of no relevance, it will not improve the patient. I think you will decline the patient's request.
So, do anybody have a counter opinion to what Dr. Sonny Emmanuel just mentioned?
Good day, sir. Sir, if I explain the patient, if the treatment is not harmful,
Excuse me,
I
can
can
we
give
know
it.
your name?
I am Fatima Mukhtar.
Oh, Fatima Mukhtar, please go ahead.
Sir, if it's not harmful, I can give it to the patient. If it's not going
You
to
said
cause any
if
harm.
it's not harmful,
Yes, sir.
you can give it to the patient.
Yes, sir.
Okay. Now, which principle are you using as a professional that you know that this treatment is not going to be effective and you still want to give it to the patient? And Dr. Sani Emmanuel, which principle are you also using that the patient has a preference and you're refusing to give it to the patient? As professionals, how do we handle that? So those are dilemmas I want us to talk about. Can any third party come in, please?
Hello, sir.
Yes.
My name is.
Mention your name.
My name is Abdulaziz Medoki, sir.
All right, go ahead.
Sir, in this case, I think you make a proper explanation to the patient because you don't have to waste the patient's time. So you use the principle of benefits and non-maleficence, sir.
Okay, thank you very much. Is it wasting only the patient's time or wasting you as a physiotherapist's time? And are we looking
Both
at
of us,
waste
sir.
of resources?
Yes,
It's
sir.
not only time, there are resources.
Yes, sir. It's
All right.
wasting everyone's time, sir, and resources.
Dr. Sonny, do you agree with him?
Yes, Prof. I think I agree totally.
Right.
Like you said, apart from wasting time and resources,
Yes.
the professional integrity is also at stake.
That is
Patients
where I
don't
want us
come
to
to
draw
the
the line. That professional integrity. Now, let me give you something added to this. It was yesterday exactly. A patient came to me. She traveled to Egypt, for review of her back pain and blah blah blah. The neurosurgeon did everything they did, gave her medications, and that they should come back for physiotherapy. Now the surgeon wrote to them that it must be once a day, once in a week physiotherapy. And they came to me for once in a week physiotherapy. Will I do a once in a week physiotherapy for the low back? Because the surgeon said we should do that? Will you do that?
Not really.
So these are the kind of issues that will come up. Now, by the time I explain to this patient what is happening and why we needed the physiotherapy, the minimum period we want is 6 weeks, 3 times in a week physio. And I was like, oh, doctor, I think we're just going to go by your word. You know, then she needs to see the professionalism in you. The patient will have to believe and be confident in you. So I want to appreciate everybody for your resourcefulness. And this is how to go about it. Now, we also have another dilemma. It says a colleague breaches a patient confidentiality. It's your colleague that wants to be talking about a patient's case. I remember, I don't know, but that doesn't remind us, was it a senator or somebody? Oh, was it the president? And his case was loose. They begin to talk about, okay, I think the present president, when he went for a knee replacement in London, and he was, I think he was being voted or something, but his clinical information got open. Just the way the royal king of London, King Charles, had a prostate surgery, and a doctor released his information to another colleague, and it got into the public. What do we do about that? If a colleague releases a patient confidentiality information, colleagues, what do we do? Yes, colleagues, please. It's important we interact about all this.
Good evening, sir.
Good evening.
My name is Muhammad Suleiman.
Okay, go ahead.
First of all, we're supposed to enlighten the colleague, remind him about the negative effect of revealing the patient confidentiality.
Okay.
And try to minimize the damage and the spread of the information as much as we can.
Beautiful. So how do we reduce that spread of information?
It's like getting to all people that knew to tell them this is very confidential and it is not ethical to be revealing it out. So we should keep this within our mates.
Exactly. Whenever anything like this happen in the ward or the theater, do you hear the doctor spreading it out that something like this happened?
No.
They don't know, so they will keep it within themselves to stop the story. Your colleague came to tell you that man, blah, 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 blah. You have to remind that colleague, you have to keep this information. And that story should stop between you guys there.
Yes.
Do you understand? So please, Usman Suleiman, thank you so much for your contribution. Very, very important. So this is how to go about it. Now, if you have a dilemma that your resources are limited, but your patient, the prioritization was not based on patient need. And then you are not the head of the hospital. You are not the head of the department. As a professional physiotherapist, how do you handle a resource limitation in terms of prioritization for the patient? What do we do there? Do you go out to buy more gadgets from your pocket, or what do you do? Hello, colleagues. Is it difficult? Is it that we have never encountered something like this in our practice?
We have, Prof.
A clinic that has only one test machine, and then we have about 20 patients needing tests. What do we do?
So we can use a random ballot selection, sir.
We do balloting. So only give the patient
I
that
would do it
takes it.
personally, like I would just randomly pick a file or pick a okay, so how about according to how they came in? First come, first serve basis. Or maybe based on emergency.
When you do
How urgent the condition?
when you do randomization or when you do first come, first serve, you still did not prioritize which patient needs it most.
So
It's
based on
about
urgency then.
evaluating your patients. You have to evaluate them, understand what will these benefits who most. Okay? Now, TENS is meant for pain relief, and then are there other things you could do to relieve the pain? So you will now see who among them needed TENS the most. So you prioritize based on needs of the patient. Okay? So it's not about randomization. Randomization puts everybody in the same box and have the same the same chances for them to be chosen, whether it's for this or for that. So the patient that needs it most may not be picked in randomization. All right. The last case I'm presenting is when you have the recommended care, the most important thing the patient needs, but the patient cannot afford it. He has no money. What do we do?
So if there's any
Only, are we giving only Fatima Mukhtar the whole presentation?
Good afternoon, sir. Good
Okay,
evening,
yes,
sir.
sorry, Fatima is still on board. I just wanted to
worries,
put
sir.
everybody up. Yes, Fatima, go ahead.
Okay, so I was saying if there's any other option that the patient can afford, if there isn't, then maybe we can get a welfare or NGOs that kind of offer, but if it's or you can even use your own pocket. You can spend it.
Fatima said physiotherapists, you guys are being paid extensively well, so therefore we should use our pocket money to enhance the care of our patient. Well, that's good. Bashir Abdulhakim Musa.
So, good evening, sir.
Good evening.
So, sir, it depends on the hospital, the patients, the environment per se. Like when I was in Sokoto, I know their social welfare works very well. So whenever we have those type of patients, we talk to the people in the social welfare.
All right.
And we find a
Thank
way
you.
of
Thank
getting.
you. Social welfare can help. Emmanuel
Yes.
is raising up his hand. Medoki is raising up his hand. So let's listen to
yes.
Dr. Emmanuel.
Prof.
Yes, go ahead, please.
Once again, good evening, Prof. You see, in cases like this, what we say, limitation of resources.
Yes.
Unable to afford the particular care.
Yes.
Now, in this case, like some of my colleagues have mentioned, physiotherapy, if there is something that we do so well, it's improvisation.
Exactly. Improvise a lot.
If that particular thing or care that the patient needs the patient could not get, we try to improvise. We we look for something that we can do to help that patient. And if it's something that care cannot be gotten at that instance, then the patient can go with some home programs. Tell the patient, do this, do that, and you get some relief.
All right, thank you so much, Abdulaziz Medoki. Emmanuel, can you raise your hand? Yes.
So, Dr. Emmanuel has actually said exactly what I'm going to say, assuming that you don't have social welfare and all other things, because it's only few hospitals that you find social welfare that can help.
That's right. So we should improvise. Now, the bottom line is this: when the patient cannot afford recommended care, you don't allow the patient to go. You will give what they call the most available care you have. Do you understand? That is the highest available care that you have. So you must give that patient that. So I think we can just move ahead. So let's see what are the steps we need to take for us to make a good ethical decision, ethical decision making. I said the first thing is we should try to identify the ethical issue or conflict. What is the problem? It means you must define the problem. What is it you are having now as a problem in this patient? Then you should be able to gather relevant information as to what are the facts and consider the perspective of all parties involved. Is it a problem coming from the doctor? Is it coming from the patient? Is it coming from the billing system of the hospital? You gather all relevant information. Now you consult ethical guidelines. I'm very sure most of us have never been reading the Nigerian Physiotherapy Professional Code of Conduct Act. We need to go back. We need to know the laws that are guiding our activities so that we know where we can walk in and where we can stop. In the UK recently, they have agreed intra-articular injection can be given by physiotherapists. So, but in Nigeria, we should know where is our own, because the law in England agrees. It doesn't mean the law in Nigeria agrees. So we must know what are the laws that govern our profession, both locally and internationally. And also, we should be able to evaluate the possible actions and their outcomes. This thing we want to do, what is the likable consequences that may follow it? Now, what are those things we want to achieve by doing what we want to do? And then we'll be able to select from every action and implement it. The moment you implement, you should be able to now come back and review that thing you have done. What is the decision? What is the impact of your decision that you have made? So these are steps you should be able to follow when you want to do or you want to make an ethical decision. So you have 6 steps you should be able to implement, and then you go back to reflect or review on those decisions and see the impact. Now let's look at a real life case study here. I said a physiotherapy notices a patient is experiencing discomfort with a physician recommended treatment. You know, you're seeing a stroke patient and the patient is coming from his physician that said he must stop using maybe a thinning medication like aspirin or clopidogrel or apixaban. So all these kind of drugs that are likely to thin the blood, and the patient, doctors ask that they should not use it. But you begin to see that your patient is going through some discomfort whenever they are not using this. Now, this patient is hesitant to show or voice their concern. So the first question I have here is, what are the ethical responsibilities of this physiotherapist in this situation? Please, can we have some other colleagues interacting? Let's have it. Because your hand is still up, can you drop it down, please? Can you guys hear me? Am I audible enough?
Yes, sir, we can hear you.
Okay, good. So let's interact with that. I said, what are the ethical responsibility of the physiotherapist in that situation?
I think physiotherapists need to consult or discuss with the medical doctor about the decision to make.
Okay, so how do you do that?
You find who is the medical doctor that said that and discuss with him as a team. You work as a team with him to come up with better solution to the patient, for the patient.
Okay, yeah, anyway, that's one way. Do we another person have any other information?
So if the doctor is in your hospital, I think as professionals, a doctor is not like a god. So you can meet him, discuss your patient with him. I'm treating my patient, but this is the problem. What do you think? Well, but if he's not in your hospital, you can meet another doctor and raise alarm. Then that doctor, as a physician, can find solution for that patient.
Good. Any other information? Any other opinion on what we should do? You're treating your patient and the patient is having some discomfort based on what a physician has recommended. Can you ask the patient to stop it or to continue it?
Once again, you can like go and research to see what is the best available evidence regarding that situation.
Well, thank you so much, Mohammed Suleiman. This is where I am going to. You must have good information about that thing. And that's what I mentioned in the other class, that we should gather information. It means you should go and read about that recommended treatment. Do you understand? so that you can interact properly with the doctor based on that medication or based on that treatment he has approved. I hope we're making sense here now, please.
Yes, it is.
Sorry.
Okay.
Do any other person have any other information, or we can move to the second one? I said, how can autonomy and beneficence be balanced in this situation? Don't forget, the patient also has his autonomy. Number two, we want any treatment that you will use to be beneficial. Okay. Chukwuemeka Johnson, your video is open. Please, can you put off your video? Chukwuemeka Johnson. And somebody who knows him to give him a phone call, please. Chukwuemeka, please put off your video. All right. So I was trying to say, how do we ensure we balance between autonomy of the patient? Since the patient is not the one speaking out, it's you as the physiotherapist that notice the problem. Do you understand? And then the principle of beneficence, how do we balance it in this case? Meidoki, your hand is still up. Do you want to speak, or you want to drop your hand down? Well, ladies and gentlemen, it's after 5, so I'm going to just rush through this while we interact. Do any person want to say something? The patient has autonomy to treat, but you have also the principle of making sure that this patient is not harmed. Do you understand? So therefore, you must come out to tell the patient, if you continue this, it will not benefit you. But these are the problems you are envisaging based on what you're doing. So therefore, you must be able to balance between autonomy and beneficence. And whenever it's going to be beneficial, we're going to take the principle of beneficence more importantly and standing with the patient. So here is the principle about when you have all these ethical dilemmas, how do we go through them in our profession or in our practice? I said we should learn how to navigate through all these dilemmas in physiotherapy. Ethical dilemmas can always arise. We must always be ready to take care of them. They arise when two or more ethical principles conflict, or when external factors challenges your ethical practice. I say handling these dilemmas require critical thinking, adherence to professional code of ethics, and then sensitivity to patient's needs. One of the common ethical dilemmas in physiotherapy is patient refusal of recommended treatment. A scenario here is a patient refuses a prescribed intervention that is critical for recovery. How will you now balance between autonomy, that this patient has right to benefit a treatment, or he doesn't want the treatment? How do we do that? We talk about the resource allocation, where resources are limited, and then we require prioritizing with this patient. You can see my slide are just scattered. I quickly rushed to prepare them. So we will learn how to read them carefully before it's sent. So, of course, there are issues concerning conflict of interest. A scenario where a physiotherapist recommends a product or service from which they will receive financial benefit. For instance, you ask a patient to go and buy a lumbar corset just because you're going to get some rebate from the lumbar corset that the patient purchased. You know, how would you resolve such type of conflict of interest? I said you must learn how to maintain professional integrity while you avoid bias. It means you should not ask the patient to buy a lumbar corset just because of that thing you want to get. But you can ask the patient to buy them when they need them most. So it means whatever you are getting is not consequential to what the patient will be benefiting from. Of course, a patient will consent a treatment but not fully understand the risks and benefits. Now, if the patient now comes to tell you that treatment that I've agreed before, I don't want us to do the treatment again, what would you do? The patient has approved that we should, he consented for a particular treatment, and now he's telling you he's not ready for the treatment anymore. What will you do? Are you going to say he doesn't have autonomy? Or you want to say because of the principle of beneficence, you want the patient to must go through the treatment? Understand? So we need to put all those things together. So these are all the frameworks we have discussed before. I still repeated them so that we can understand. Now let's look at these case studies so that we can discuss them. I said a patient demands a treatment that is not supported by evidence, but the patient believes that treatment will help him. I said, how do you maintain professional integrity while respecting the patient's beliefs? You know, as maybe Jehovah's Witness, they don't agree for blood transfusion, and your patient presented with 15% PCV. What would you do, knowing that the patient needs transfusion? Will you agree to do the treatment? Would the patient believes does not like your treatment? What would you do? Will you allow the patient to die? Hello, are we together?
Good evening, sir.
Yes, good evening.
You explain to the patient about the benefit of it and try to convince him for him to have it. And if he still didn't agree, then
Yes.
there is guidance and counseling unit in the hospital, or is it psycho?
Yes.
To them.
Yes. Any other person? Can we have a scenario in physiotherapy where this can happen? Has anybody had an experience where he had a situation like this? Where a patient wants you to do a specific treatment, but there is no evidence for you to do it, but the patient believes that thing will help them. Have you ever experienced that? Now, a patient came to me just today. The patient had a fracture of the lateral malleolus of his ankle about almost a year ago. Now, this fracture led to a secondary arthritis in the ankle joint. And of course, there's a kind of shortening of that limb. It's quite an apparent shortening. Now, he told me he once visited a traditional bone center that was pushing the leg backward until his pain released. And that he wants me to do the same pushing. Knowing that the more I push, the more I'm creating more arthritic changes in that ankle. Am I going to do that, even though the patient believes is going to help? Should I do that, colleagues?
No, sir, you won't do that.
So why? Who is speaking? Let's have your name. Yes, go ahead. What are your reasons?
Sir, this is Aisha here.
Oh, Aisha. Okay, go ahead. What are the reasons why you say we should not do it?
Because, sir, you know you're going to cause more damage than good. So even though it's the patient's belief, you are going to explain to the patient why you can't do it.
Yes, thank you so much. Don't forget we have the principle of maleficence. It is the principle of causing no harm. Do you understand? The patient has his autonomy to choose a treatment. But at the same time, also have the right that that treatment has to be beneficial and that treatment should not fail. So if I know that what I'm doing is going to harm the patient, then it is also a principle that I need to not do it. But how do I make sure the patient gets to understand and accept this situation? How am I going to balance it? How do I make the patient know that as a professional to respect my patient belief, I respect the autonomy of the patient, and also do what is right? How do I put these two together? Mr. Sonny, you want to say something? Sonny Emmanuel?
Thank you, Prof.
Is that very tight?
No. It's okay. I'll be listening keenly because, like Aisha just said,
Mentioned.
I think
Yes.
what we need to here is really information, informing the patient,
Educating the patient.
convincing the patient
Educating the patient is very, very important.
Thank you, Prof. Educating the patient on why what he is asking for will not be beneficial to him, rather will be harmful. And let the patient know why you want to do what you should do that will benefit the patient and not what the patient is asking for.
Exactly. It's just like your baby's at home. Your baby has malaria. Because you love the baby, you don't want him to take a bitter pill. Are you going to give a sweet or are you going to give a chloroquine? If you really love the baby, what do?
You give the chloroquine.
You see, it doesn't mean you don't like the baby, right?
You like the baby because yes,
you want the baby to be well.
You want the baby to be well, so you give what the baby needs, the beneficence.
Exactly. Principle of beneficence. Don't want to harm the baby. Now, another scenario is this. I said a supervisor, that is a senior physiotherapist or who you're working under, ask you to write a false document so that you can meet up with the hospital goal. Now, I'm bringing this up because this is what most of us used to do whenever we hear that MRTB is coming for, what do they do? Accreditation, or the NUC is coming for accreditation. We begin to do what? To pimp up the hospital. We pimp the department. We'll put this one. We'll put that one. Even though those things are not available, we'll borrow offices. Is it right for us to have done that? If a supervisor asks you to do that, falsify a document, maybe just to meet up with the institutional goal for accreditation, are we supposed to be doing that as professionals? Would you do that? Because we're talking about now, how do you maintain professional integrity between your senior colleague and you? I'm saying senior colleague here, maybe the HOD asks you to do that. You don't have a lesson machine and they say you should write that you have a lesson machine. Are we supposed to do that? Because we want to get accreditation. Nobody is speaking. So is that what we have been doing?
No, we are not supposed to do that.
We are not supposed to, but we have been doing. Is that what we have been doing?
No, sir.
Nobody is speaking. Maybe I should be calling some colleagues. Okay. Aroloye Fumilola. Madam, we need your contribution. Please, what do we do here? Mrs. Aroloye, is she there? I don't want the one most of us will just mute and we're not following the discussion. We need to learn from ourselves. Let's learn from different institutions. What is going on? Yes. She's not there. Femini. Apata Femini, is she there? Huh? Most of us are not there.
We are here, Prof. We are here.
You know, those who have not been speaking, there's somebody down there, Gali Yusuf Ahmed. Gali, are you there? Gali is also not there. Eitayo Olufemi, are you there? Halima Muhammad Isa.
Good evening, sir. I'm here, sir. I'm just.
Gali, okay, have you been following or you just connected and you're sleeping on your bed?
No, sir. I just slept a few minutes to see one patient.
Oh, you're still in the clinic. Okay, good enough. All right.
Thank you, but
Hawa Achimugu, are you there? We want to know, what would you do when your supervisor asks you to falsify a document just to meet up with the hospital or your institutional goal? Will you do it? Or what are the ethical principles that have been violated? And then how should you respond to your senior colleague or the HOD that say you should do that? How should you handle that situation? You start. Okay, Ricky, are you there? It's like most of us are just there in name, but we're not there in person.
Hello, Prof.
Good evening,
Prof.
welcome on board. Good evening.
I'm Isaiah Olufemi Adeji.
All right. Okay,
From my own perspective, are you hearing me?
Yes, we can hear you.
Yes, sir. From my own perspective, there's a lot to be done as regards what you just raised up now.
Yes.
Because in a scenario like this, you won't want to hurt your immediate
HOD or supervisor,
your whatever. And secondly, by virtue of things that we're doing, you will not make the hospital to grow as well, because most of the equipment or whatsoever that is not available, they will, the authority and the school and the hospital as well, they will think that we're having all those stuff there. Let's be realistic on something.
Exactly.
This is not available. It is not available. If it is available, it is not available. So by the time you are doing that, whenever MRTP comes for accreditation and they leave, what about the legacy you are going to leave there? And as regards the patient that you are treating, you want to treat the patient that is having what is it called? Let's assume that is having sciatic injury, and you know you need tents, and the tents is not available, and the patient has made payment. And what is the basis of paying for what you are not going to get at the end of the day?
Exactly.
So that's the observation. Maybe probably you can just tell your head of the department, sir, it's not that I cannot do it. Can you look it from my own angle as well? We need all this all the while, and there's nothing we can do about it when you don't have it. Subsequently, there's going to be some other patient that will be coming as well that are going to need this. Why don't you tell the authority if there's any way that you can find this thing? Not that we go borrowing somewhere else. This has been going on for a long time. This has been going on for a long time. Which are reluctantly as a person that don't fight.
Thank you so much, Dr. Femi, because I know these are the realities, and that's why I'm bringing them up here. And let's see, what are these? We should know we're rubbishing our professional principles when we do these things. It's everywhere. Even in my system, in my institution, the day they will say the president is coming, you will come and see new bed sheet inside the hospitals. You will come and see the CMD has made sure that there is a new motorable road in the hospital. You will see that everywhere. I mean, how do you want to tell the president we don't have ABCD? Why didn't you allow him to come and see what is always there so that he will know the problems we are facing? So these please should stop. Because we're being governed by some ethical principles. That's why we're professionals. When a supervisor asks us to falsify information or documentation, we should respond to that individual with respect. That with all due respect, sir, I think this has violated the ethical principles of what? Justice, fairness, and all that. And then you mentioned that's why you're not going to be responding or writing that. So I think this is just where I'm trying to push this presentation. Thank you so much. So let's just quickly go to the legal responsibilities that we're supposed to know about ourselves as physiotherapists. I said legal responsibility in physiotherapy is it's what protects the patient's rights, safety, and professional accountability. And therefore, we must adhere to this legal framework that in order to prevent litigation and maintain professional integrity. Unfortunately, who takes a doctor or the therapist to the court in Nigeria? Who can ask them in UK? You'll be stripped out of your certificate. But unfortunately, most of us as physiotherapists don't even know the law that established the profession, the act. So we need to go back and read. Sorry. Now, we have some core legal obligations upon us as physiotherapists. This first one is our documentation and record keeping. Whatever this our clerking, the file that we normally clerk and write everything about our patient, we say we should make sure that it is an accurate documentation, and is a legal requirement and professional standard. That, for instance, a husband comes to say his wife presented with ABCD, but we did this and that and that. But your documentation in any court of law that we go to is what is going to, to exonerate you. I remember one of our colleagues here in Canada was called to testify on a patient in the court. He was treating the patient. So you wouldn't know the day that your legal backing will come up. Let's ensure that we keep up to our best practice. And I said the best practice ensure, or rather include, we ensure that we record all our patient interaction. Whenever you see your patient, you should clap patient presented today. You write date. We presented with what and what did you do? You write it there. We said we should include the assessment, the treatment, and outcome of what we gave. We should ensure that our records are usually clear, concise, and completed promptly. Don't write the medical jargons and people cannot understand. You say, no, this is how medical doctor writes. No. If you go to a court of law and nobody can read it, okay, is what the judge will present is what you will be taking, because your word could not stand for you. So we should ensure we write clearly and concisely. We should also store all our records securely. I'm happy these days most of our clinics are using medical, electronic medical records. So these can be left for a long period of time and we'll meet it there. Now let's look at our informed consent. This is part of the legal document we should have. Whatever treatment you want to give. You can imagine if you are working in somewhere like the northern part of Nigeria, just imagine you're a physiotherapist in Kano. A patient presented with coccidiosis. How do you want to manipulate a woman with coccidynia? Who want to do that? Those working in Kano. You know, as a manual therapist, how am I supposed to do that? Huh? You want to assess the back of a woman and you're working in a Kano setting. How would you do that? So we must understand that there are a lot of settings and that anything you want to start with, you need the patient informed consent. Informed consent means you must start by explaining to the patient clearly the procedure, the potential risks, the expected benefits of what you want to do. Madam, I want to expose your back. I want to see ABCD. We want to do 1, 2, 3, 4. Do you agree? When you ask that, I want to tell you in Kano, 99% of women would rather go without the treatment. If there is no any other woman that will help do the treatment, they will not accept. So therefore, you can't just come in, just imagine you are coming from the southeast or southwest and you don't know the culture here. And then you just saw a woman with back problem and you want to say, okay, madam, open your back. You shout, you will hear, it is the next police station you see yourself. So please, we must work with informed consent. As patients have the right to understand and agree to their treatment plans. We should clearly explain the procedure, potential risks, and expected benefits. We should document the patient consent in their record. So right where the patient agreed for the treatment and the patient should sign. We should be able to obtain consent from minors or incapacitated individuals from legal guardians. That is from their parents, their guardian, and all that. Usually here for minors, we don't call it consent, that's accent. So we accept their accent from their parents. And of course, the issue of confidentiality and privacy also work. Means we must understand and comply by the data protection laws. We don't know what are these laws in Nigeria. So these are the documents we must try to start reading as professionals. So that when somebody says you have exposed their document, you wouldn't know where that individual will go. I want to give you a short story. Yesterday, I was discussing with a friend from a bank. He's a bank regional manager. We're discussing. And he told me there was one time he had a serious trouble with one of his youngsters. I said, what happened? He said, a man who this staff, they live in the same community, came to him to ask for money for borrow, knowing that he works in a bank. Do you understand? Now you don't say, how am I going to get 10 million to borrow you? Why don't you ask Mr. ABCD that live just around 2 steps from your house? He said, Mr. ABCD, we don't see him as any money man. I said, look, I can show you his bank account. He came to meet him in the bank. So he opened the bank account and showed him like this. And the man said, the next thing is to the ABCD man's house. Salam alaikum. And they discussed, I need you to borrow me this 10 million. Do I need it seriously? I don't have money now. No, don't tell me you don't have money. They have showed me your account details. They showed me this is how much you tell me you don't want to give me. He said, he closed his mouth. He said, well, I don't have. The next thing is for him to get to that bank. And he said, where is the manager? And that was when this manager, this my friend, came into the trouble. One of your staff showed my account to somebody who came to my house to borrow money. And I know the staff because he lives around here too. So he's the one that will know that person. The short story is that he said he must take away all his account. They must close that account for him that day. The manager said he begged heaven and earth. No way. The man refused that. He must transfer all his money, over 130 million, was moved from one account on one day. That the next call he got from the headquarters, who is this person that closed his account? That he got queried. They took him. It's just lucky that this man just closed the account and moved his account because he said his life is under threat. It means they can tell somebody that will come and kill him. So you can imagine when you don't even understand when you issue out people's information. So please, these are some issues we must know that they can happen. So it's the same thing. You can just be discussing with somebody. You don't know this man. He came to our clinic. He's HIV positive. You don't know him. So things like that, you won't know where it will get to. So please, let's know the law backing these things. Now, we should also understand the scope of our practice. Physiotherapists must practice within their scope as defined by the regulatory bodies. I mentioned that in England, we have approved physiotherapists to give intra-articular injection. Is that approved in Nigeria? Is no. You have to go and look into the law that the scope of practice in Nigeria. So you don't want to be doing what is not your mental work to do. So you have to guide yourself as a professional. So we should avoid diagnosing conditions that are beyond our expertise. We should refrain from prescribing medication if it's not authorized. Of course, we should also understand the duty of our care and negligence. The duty of our care is that we should provide competent and evidence-based care to all patients. And then our negligence is that it's our failure to meet this standard care, which may lead to harm or lead to legal action. So we should understand from our ethics book and legal book what is the scope of our practice. Then some common legal issues in physiotherapy include failure to obtain consent, breach of confidentiality. And I said the breach of confidentiality can just be an unintentional sharing of patient information. You did not intend to tell this thing, but maybe you like talking story and you tell a story about the patient, and that thing has happened. So it can lead you to something. Of course, one common legal issue in physiotherapy is documentation errors. You want to say this patient has maybe carpal tunnel syndrome, and you wrote, you want to give a different disease, and that thing went to court, and they came to your documentation. This is what you say. So the disability, whatever they are going to charge you, is going to be so high. So these are common things we find in our practice. And of course, another legal issue is when we practice beyond our scope. What you are not supposed to do, you are doing. What are the steps we can use to mitigate this legal risk? Number one, we should know the laws and regulations of our local body and of course international body. We should always remain competent. That is, we should develop ourselves with updated knowledge. We should participate in regular professional development programs like what we are doing today to ensure that our skills align with the current standards. Of course, when there is an issue, We should not use that because we are physiotherapists, we are professional. No, we should try to seek legal counsel. Let's get a lawyer. Let's get a solicitor or a barrister that will stand for us. Don't go and say you can stand for yourself. That one can kill you. And of course, we should try to foster open communication. We should encourage our patients to tell us their problem, to let us know what is going on so that we can address them appropriately. Now, I'm bringing up a scenario again that a physiotherapist unintentionally shares a patient's medical history with another patient due to a misplaced file. Do you understand what is happening? You went to the ward, you wanted to see a patient. Let's assume the person's name is Muhammad Bashir. And the patient you went to meet on bed is Bashir Muhammad. And then you begin to talk about this patient continuously. You did not confirm, is it this patient you have come to see or not? Until you gave this patient the whole information about that other patient. Then I say, I know that is the other patient over there. What immediate step will you take to correct this problem? Yes, please. Who can tell me what would you do? Because already there's breach of confidentiality. What would you do immediately, you know, to stop this problem? What immediate step will the physiotherapist take? Yes, colleagues, please open up. We there? You can see Inia Precious with Dilma. I can see Isa Nazivin, Ishaq Ibrahim. Yes. There's Ngozi Nadike, Opina, Ugochukwu, Nature Favor. Please, somebody should speak up. These things can happen to us. I don't want to be calling Mr. Emmanuel again.
Good evening, sir.
Good evening.
I think what to do is to quickly admit that this is a mistake and ask the patient that you mistakenly told the information to please not to say it to anyone. And if the intended patient knew about the expulsion of the information, you tell him that the information has gone out and he should be patient. You apologize to him too.
Okay, thank you so much. Any other person? Genius, Ikenna, are you there? Genius. Genius, I can hear you. Go ahead. Hello.
Hello, Prof.
Okay, do we have that? Yes, please, I can hear you. Go ahead. Go ahead, go ahead. Our time, we are running out of time. Ibrahim Ade Toye. You Ade, is that? Yes. Speak.
Sir.
Yes, please go ahead.
Okay, I'm Sakina Ali.
Okay,
What
Sakina,
I will actually do is I will actually confuse the patient. The information given. I will tell him, oh, sorry. I said Bashir Muhammad Bashir. Oh, I think it's for Abubakar Abdullahi, the person that died yesterday or so, something like that. So ask more confidential. Because by you telling him to not say it, that is not a guarantee.
That is when you have even asked him to go and say it, because that's how we are as human beings.
Yes.
So it is, number one, just like what the first speaker said, you take responsibility. Oh, it's a mistake. I think this is for that patient we lost yesterday. You know? So number two, you don't let him understand who is the real patient you were looking for. Are we together? So These are some of the ways we can use to quickly mitigate the problem that came up. So now, how can we as physiotherapy prevent such incidents from happening again? What do we do? My colleagues, you guys are here, but most are not participating.
Good evening, sir.
Yes, good evening. Good evening.
I feel how we can prevent such incidents from happening is by confirming the name of the patients before attending to them or talking. Or when we, let's say we get to the ward and we have to see a patient, like you said, Bashir Mohammed and Mohammed Bashir, we'll confirm the patient's name. And then while filing also, if there's a possibility of including a third name in the patient's file, so we can ascertain that this is the patient we're actually coming to see.
Oh, perfect. Now, any other person? Those are good.
Hello.
Hello,
yes.
ma.
Hello, sir.
Yes, Chiwe Obikwe, you can go ahead. You are on board.
Good evening, Prof.
Good
I think
evening.
one of the ways we can prevent this such scenario from happening in the first place is we have to have a structure of how we approach patients, because this is likely to be a first-time patient, like the patient you're seeing for the first time.
Yes.
If we have a structure of how to approach the patient, when we get to the ward, look at the patient's information, as one of our colleagues has just said, and then confirm with the nurses. You know, I'm here to see Bashir Mohammed. And they say, that's Bashir Mohammed there. And when we approach the patient, we confirm from the patient, you know, getting to know the patient, oh, you're Bashir Mohammed. And then if the folder says 61 years old, because you should have gone through that information, and you're looking at a young man that's still very young, that should make you suspect, are you this? And how old are you, or something like that? When we look at the patients, for example, the demographics, for example, we have that structure of going through this for first-time patient, then we can know for sure that this is Bashir Mohammed, not Mohammed Bashir. That's one thing I think, that if we have that structure of always confirming that I'm talking to the right person. And if somebody says something about having a third name, it's something we should escalate to our records, department or hospital management. Every patient must have a third name. And then we have to be sure that all the patient information are duly captured. If some information are missing, we should find out, so that I'll be sure maybe this Bashir Mohammed is from Kano, the other one is from Kaduna. Then in that interaction, we can really clear. Thank you very much, sir.
Thank you so much, Mr. Obikwe. This is quite fantastic. But we need to understand that most of our work, or the discussion we're saying now, it's when we are working at STP, at a standard temperature and pressure. Most of us, when we work, we're working either under pressure, overloaded work. You're tired. You don't have time for all this. One major issue I want us to take home here is we should learn how to code all our patients. When patient gets in with coding, you are less likely to miss out your patient. Patient that comes with code are not going to be mixed with names. There's no way you come up with names, you're likely going to mix them up. You speak with patient nurse, the nurse that knows the patient is the one on duty. Another person you are speaking with do not know the patient. They can also throw you into another malfunction or another mistake. So I think the best way is for us to learn how to code our files. Mr. Bashir, AB, these AB are those on here, these are this and that. So coding is one of the best ways to solve most of these problems. Thank you so much, everybody, for interacting. We quickly dash in to finish up today's work by seeing what is our role, what are the roles and responsibility of a physiotherapist. I said physiotherapists play a multifaceted role in healthcare, extending beyond patient treatment to include education, advocacy, and interprofessional collaboration. These roles are guided by professional standards, ethical frameworks, and societal expectations. So among them is one, being a clinician. We know you need to assess, diagnose, and treat patients. As an educator, you provide patients with health education, preventive strategies to improve self-management. You advocate, you try to promote the rights of patients to access equitable and quality care. You are, as a physiotherapist, you can work as a researcher. You engage in clinical research to advance knowledge and improve practice standard. Of course, you disseminate findings by going to presentation, workshops, and you make publications. Please, at this point, I want us to understand that research is not meant for academic reasons. All over the world, clinicians are the bedrock of researchers. Clinicians are the ones who interact with these patients. Academicians don't usually interact with patients. So don't ever think when they say research. Academicians go into research because it's a necessity for their promotion. Clinicians don't go to research because they don't need it for promotion, but it is they who are the custodian of all these patients. They are the ones who knows what is right for the patient. So they are the ones who should give us the challenges on how to pick up research. So we should ensure that most of us as clinicians begin to motivate ourselves to do publications, presentations, and delve into research. And of course, as physiotherapy, we have the role to play as leaders as well as collaborators, because you can be the lead person in any rehabilitation pattern. You have different rehabilitation roles that you want to do, maybe in disaster management, emergency services. There are times that you as the physiotherapist will be the leader. And of course, we should be able to collaborate with all other professionals for holistic care of the patient. I think our key responsibilities are we want to do a patient-centered care. All our concern is about to prioritize the needs, preferences, and values of our patients. We want to ensure that we stay up to date in physiotherapy advancement. So our continuous education, like what we are doing, I'm sure this is why the MRTB is bent on saying we must have our CPDs complete before we can renew our licenses, just to keep us up to date. And of course, our ethical practice is one of our responsibility. So please, we should not be seeing our CPDs as a way of just making money. It's about how to update our knowledge, how to make us stay advanced in our profession. And of course, we should be engaged as professionals in physiotherapy in health promotion and prevention. So it's not just being in the clinic. We should learn how to go to the communities and tell people about how to live a healthy lifestyle. And of course, lastly, we also have management and administrative duties we must do. That is in how to maintain accurate documentation and patient record, and how to bring about policy that will help to gain mass more resources for our profession. There are other expanded roles we should know that physiotherapy are doing now, like the telehealth services, the global health initiatives, the specialized role, in which we have the women's health, geriatrics, sports, and all that. And of course, we have the policy and advocacy, how we bring policies that will promote integration of physiotherapy all cares. These are the things we try to do, as professionals. This is our key aspect, how we ensure being professional. Number one, we must learn how to do interpersonal communication. If we don't do this in good way, you don't listen to people, you don't listen to a patient and other professionals, you may not be taking yourself as a professional. So interpersonal communication is key for our profession to grow. Of course, we must always try to appear very clean and neat. We conduct ourselves. How could somebody wear bathroom slippers to office? I mean, who does that? You conduct yourself in a manner. You cannot be a physiotherapist and buy akara eating on the road. Why should you do that? I mean, you buy it, go to a corner, sit down and eat. You should be able to lead team collaboration, and then if there is any conflict, you must learn how to do good conflict resolution. Time management, accountability are all what makes us professionals. So please, let's hold on to that. We have some common challenges that we can have as professionals, like burnout and stress. I just mentioned, we're always working under stress, So when you're tired and there's burnout, you must learn how to go for relaxation, how to take some leave. And of course, when there's conflict with colleagues, you must learn how to manage this conflict. And of course, we talked about the ethical elements. So there are 3 tips I gave for maintaining professionalism. Number one, we should always reflect regularly on your practice and identify areas for improvement. You should try to attend workshops and training to enhance your communication and team skills. And then you seek feedback from colleagues and supervisors to grow professionally. Thank you all for listening, and I hope I have not taken all our time. Thank you so much. I hope we can meet some other time to share more information. Good evening, all. Any question?
Wow. Thank you, sir.
Yeah, thank you very much, sir. That has been
Thank you
an
very much.
enlightening.
It's been an awesome lecture. We really gained so much. Thank you so much, Prof. I really
Thank you
appreciate it.
very much.
Hello, sir.
Thank you,
Hello,
Prof.
sir.
We are really
Hello,
grateful.
Prof.
Yes,
Hello, Prof. Hello,
yes, good
Prof.
evening. Go
Hello,
ahead.
Prof. Okay, sir.
Miss-
I could have loved so much for you to have asked this for your added to your presentation.
Yes.
I want us to talk about, there's no more time for us anyway. I want us to talk about sexual advancement and sexual harassment. It might probably be the next lecture if anybody's going to take that presentation anyway.
Okay,
Because
I
something
think we're going to know that. Well,
okay, sir. It's all right. That's just a question I want to ask, so that we can just discuss a lot about it. Mhm. That's just it. Because there was a time when I was a young physiotherapist when I started work. There's a woman that are making an advancement, and some other physiotherapists as well. As their patient, they don't have the guts to even go to the extent of telling their patient that they want to date the patient or they want to go out with. This woman that I was talk with, when I was treating the woman used to go to the extent of those, if you understand what I'm saying. So by the time I realized all this fact, then I have to call the assistant that happens to be in my office. Anytime I want to treat the woman, I must make sure that the assistant woman that stays with me in the office is always there anytime I want to treat her. So that was how I was able to beat the woman hands down. So maybe we can be able to talk because it's tantamount to being license being revoked, and then the legal implication there too is there. So that's the reason why I want us to raise this issue. Thank you, sir.
Emeka.
Good evening, sir.
Emeka Chikelu.
My boss, I greet you, sir.
Now you just dey come when the meeting finish.
No be now. I've been going in and out.
Okay, now you just.
I've been going in and out. I've been here since morning. So, but once I go out, I
Please,
come
do we
back
have
in.
another presentation? Sorry, please, excuse me, colleague. Do you have another presentation?
Hello, sir. Can you hear me?
Isn't it just research methodology and professionalism?
Sure.
Okay, thank you.
I don't think there's any again. Dogo.
Wait, sir. I'm on my way out, sir.
You don't buy car, you know, tell me.
You see me with steady.
It doesn't matter now. Maybe you decided to sit by the side and enjoy yourself.
Which kind of decision be that one?
It happen now. You know that country where you don't make plenty money, you don't want to drive car by yourself. Drive yourself now stress.
Where I never even drive at all. I ain't go down tire.
And now big men, many big men never drive at all. That shows it's a sign of good living.
Oh, sorry, please, guys. I'm so sorry. I don't know what happened to the system. The thing just went off like that from my side.
Well, sir.
Yes, thank you so much.
This is Mr.
All right. I lost the last speaker that was saying we should try put sexual harassment in terms of professionalism for our next presentation. We're going to do that, God's willing. All right. So, I think we have come to the end of the presentation. We're so sorry we couldn't ask. Isa Abdullah, you are raising your hand. You want to ask a question?
Yes, sir, I want to ask a question.
Please, quickly.
Okay, thank you for the insightful session, Prof.
Yeah.
Prof, my question is about prognosis.
Yes.
Sometimes patients may come to you having paid their physio bills.
Yes.
And they want you to instantly tell them when they can recover and get back to their pre-injury status. How do you go about this from ethical perspective?
Of course, it is more ethical for you to, track your patient, evaluate, examine, and then make a diagnosis, make your treatment plan, and design from your treatment plan and information you have gathered, how long are you expected to work on this patient? You should not treat a patient till thy kingdom come. Each type of a problem has a minimum. For instance, if you're looking at a ligamentous injury or a muscular injury, or you're looking at a joint problem, you all know at what point you're expecting healing. At what point of this injury did you come up and meet the patient? What is the degree of injury? So your proper diagnosis, your proper evaluation is what will tell the outcome you're going to get at the end of the day. And so you'll be able to tell the patient, I'm working on your low back. Now we're going to do these exercises because we know exercises have its prescription. You want to treat your patient with low back pain using some exercises and other modalities. The minimum for your exercise to become very effective is a minimum of 6 weeks and 3 times weekly. Not the kind of physio that you tell a patient to come once in a week, or you ask the patient to come once in 2 weeks. What are you going to benefit? So please, we must learn to know the right thing so that you can give a proper prognosis. I hope that helps.
Yes, sir. Thank you, sir.
Now, any other question? All right, colleagues, it has been a long, long day for all of us. And then I really need everybody to go and rest. And I wish you a very wonderful new year as we are bouncing into it in the next few hours. Enjoy your holiday and have a wonderful evening. Thank you so much and Happy New Year in advance.
Thank you, Prof. Thank you very much.
Thank you. Happy New Year to everyone in advance.
Thank you, Prof. Happy New Year to everyone in advance.
Gali ya ne? Gali Yusuf.
Class rep.
Ina ta shiga ne mutumi na kwana biyu.
Wallahi sa a yanzu ma ina cikin patient shi yasa na zama busy. Muna gefe.
Oke, kana clinic ne?
Eh wallahi shi yasa.
Gaskiya ne. Ai, gaskiya prof ya motsa ilimi sosai ba.
Ka buya.
Wai an gama presentation.
Wallahi ina nan gani wallahi kuma ina shigowa Kano sosai ina program bana ganin ka.
Wayyo Allah. Wallahi rashin sani.
Ba AKT kake aiki ba kenan.
Na?
Ba AKT aiki ba?
A HMB nake.
Ok, muna haɗuwa da su CSR duk ina ganin su Hafiz, amma kai ba mu taɓa haɗuwa ba.
Kai? Yanzu ina Murtala ne.
Ok, ka koma HMB.
HMB.
Da ala kuna tare da su Huzaifa Imam kenan.
Awo, ina suke a zo a ta.
Allah ya jagora, Allah ya taimako.
Amin, na gode class rep, na gode sosai. Na gode.
A gaishe da mutanen Murtala.
Za su ji insha Allah. Godiya nake staff. A clinic din da nake zuwa ma akwai staff ɗinmu da zai zo muku kwanan nan na ga ya samu aiki a nan.
Abadallah.
Allah yanzu na ga offer kwanan nan ya zo ya karɓi offer ɗin a nan FMC ɗin taku.
Ni fa wace FMC kake magana?
Ta Gusau mana ko ka bar Gusau?
Ba tun yaushe. A ni yanzu ina ABU ne shika.
Hawa.
Wallahi Allah.
Sorry kai. Sai zuwa na kuma hawa ka yi sayo ABU kake dama ni kafa na gani ta yi class sai yanzu na gani.
Ok, ka ɗauka Suleiman ne?
Ba Suleiman ba akwai Muhammad.
Ok, na gani. Muhammad yana tare da Ani ya yi.
Yawwa, yes, exactly. Ai kai da class ai kuntar da mu. Mu muna internship ba mu gama
kuma da ka ce min Gusau ka san nan ne NYSC dina ai.
Sai kuma abin coincidence ne.
Na yi aiki a FMC.
Wallahi coincidence ne kuma kawai ce. Allah ya taimaka kuna tare da su oga ba shi kenan har yanzu.
Muna. Oga ba shi ya dawo PhD yayi.
Na ga shi nan ma yana sun yi wannan da shi da karfayi kuma wannan workshop.
Professor Fayi Adamu ko Professor Fayi Ahmad Yusuf registrar.
Shi.
Ok, dama ai mutumin registrar ne yayi. Kuma shi chairman na Kaduna.
Okay, NSP ko?
NSP,
to gaskiya ne dole za su haɗe.
Wallahi kuwa, wallahi abubuwan ne sai an kula. Oga ya zo ya rikita abubuwa. License ma wallahi in kai applying ba za su yi responding ba. Tun ina ga 14th ne applying na yanzu ba wani acknowledgement ba wani response.
Subhanallahi. Ai inda ba ciwon kai ba jini. Yanzu gashi nan
mutane da yawa ba.
Ya samu sai an yi wani domain waye.
Wallahi mutane ba su saba da wannan tsarin ba an rikita ma mutane lissafi.
Yawa da ya ba mu kamar a ce next year throughout next year sai a fara kowa ya san da abin tun January.
Wallahi kuwa wallahi yanzu tsarin nan mutanen da ba za su yi license ba suna da yawa wallahi da wanda za su biya fine next year.
A za a yi fine fa za a yi fine. Ai haka tunda kan ka cika criteria din gaskiya da wahala.
Wallahi kuwa wallahi. Abin ya yi yawa. Ko admission letter kace da ita ta postgraduate studies. Wallahi wani professional da ko leadership domain ne tukunna kafin ma a kalle ka.
Again?
Wallahi sabon tsarin kenan.
Prof sai a sai shi.
Kai prof ai babban kai ne yayi in ya buga ma in ya gwara muku kai wani lokacin ko.
Muna nan muna bin sa. Amin amin da kai sa.
Allah ya ba mu sa'a. Allah ya ba mu sa'a.
Amin na gode sosai.
Yawwa. Sai an jima.
Yawwa.